Magnesium ions are highly reactive, unstable, and easily form compounds with other substances. Hence, magnesium supplements are never pure magnesium. Magnesium ions bind with negatively charged molecules, anions, to form salts, or can bind with amino acid to form amino acid complexes. Organic complexes are magnesium trisinate, magnesium taurate. Organic soluble salts are magnesium citrate, magnesium lactate, and magnesium gluconate. Inorganic soluble salts are magnesium chloride and magnesium sulfate. Insoluble salts are magnesium oxide, magnesium carbonate, and magnesium hydroxide. Magnesium citrate salts are the great source of soluble bioavailable magnesium with a high elemental load, but you need to keep the pH low. Magnesium levels can be restored via the supplementation. Excess magnesium cannot be stored, making mega dosing unnecessary and wasteful. Some of the common magnesium formulations are listed here. They are magnesium oxide, magnesium hydroxide, magnesium citrate, magnesium gluconate, magnesium chloride, magnesium sulfate, and magnesium sulfate, oral magnesium sulfate, magnesium lactate, magnesium aspartate chlorate. Split dosing increases the magnesium in uptake and retention more effectively than single dosing. The relative absorption of magnesium is inversely related to ingested dose, so quantity of magnesium in the digestive tract is the major factor controlling the amount of magnesium absorbed. Magnesium absorption is not the same as magnesium retention. High plasma levels can lead to increased magnesium excretion. Low dose magnesium taken several times a day is better absorbed and retained. Low elemental magnesium is also less likely to cause diarrhea. Taking 300 mg magnesium as 300 mg will raise the magnesium status more effectively than one single dose of 300 mg. Parenteral use of magnesium. Magnesium sulfate, intravenous or intramuscular, has been shown to be relatively effective for treating eclampsia and preeclampsia and found to be superior to phenytoin and lytic cocktail. Intravenous magnesium is useful for correcting the uncommon ventricular tachycardia like torsades. Intravenous magnesium is useful for the acute management of rapid atrial fibrillation. Intravenous magnesium is useful in acute asthma also. Adverse effects. Although oral magnesium supplementation is well tolerated, magnesium can cause gastrointestinal symptoms including nausea, vomiting, and diarrhea. Overdose of magnesium may cause thirst, hypotension, drowsiness, muscle weakness, respiratory depression, cardiac arrhythmias, coma, and death. In patients with renal insufficiency, magnesium administration may lead to heart block or hypermagnesemia. Summary. Magnesium is the second most common intracellular cation. Magnesium is a cofactor for more than 300 metabolic reactions. Magnesium homeostasis is maintained by intestinal absorption and renal excretion. Magnesium supplementation is effective in management of many neurological and hormonal disorders and many scientific diseases. Thank you.
Thank you, sir. Very elaborative discussion on trace element magnesium. We will have question answer discussion at the end of the session. Next, we will move on to the next topic. Chase the Annoying and Managing Chronic Cough by Dr. K. Lavanya from Tirunelveli.
There is an announcement, 4 to 5, there is a quiz program in Focus Hall. All PG students can participate. Now I invite Dr. Lavanyamam from Tirunelveli to present on the topic chase and annoying the magnesium and chronic cough.
ஜங்ஷன் பாக்ஸ் வேணுண்ணா டக்குண்ணா பத்தாதுண்ணா லென்த்து பத்தாதுண்ணா எங்கண்ணா இந்தாங்க இந்தாங்க இப்படி தான் இருக்கும்.
Good afternoon to all. I am Dr. Lavanya. I would like to thank Scientific Committee of Tapicon 2025 for giving me this opportunity to present in this stage. I am going to talk about chronic cough and its management. Cough is defined as forced expulsive maneuver against a closed glottis associated with a characteristic sound, often present for a transient period of time, to facilitate the removal of mucus, noxious substances, and pathogens from the airways and lungs. So, on one hand, ineffective cough produces this retention of mucus, noxious substances, which predispose to infections. On the other hand, prolonged chronic cough causes lot of complications to the patients, which includes muscular pain, musculoskeletal pain, stress incontinence, cough syncope, psychological effects, and also it puts more of economic burden on the health sector side for detailed evaluation and treatment. Cough reflex arc. The cough receptors are present not only in the pharynx, larynx, trachea, it also present in the ear canals, eardrums, pleura, pericardium, and esophagus and stomach. There are two types of receptor present in the vagal nerve. One is mechanoreceptor, which is responsible for mechanical stimulus, and these are the chemoreceptors. This TRPA1, TRPV1, and P2X3, all these act as the chemoreceptors. All the noxious stimulus like histamine, proteases, leukotrienes, all these act via these chemoreceptors and result in the production of cough impulse. So it's carried via the A delta C fibers to the cough center, which is located in the posterolateral portion of the medulla, that is nucleus tractus solitarius, which further receives information from the cortex and modulates that result in the production of cough. This is the new P2X3 antagonist. So this blocker is the current era of treatment under further trial for future use. That is ATP receptor antagonist. Gefapixant is the prototype of drug. Cough is classified based on duration into acute, subacute, and chronic cough. Chronic cough is more than 8 weeks in adults and more than 4 weeks in children. That is classified as chronic cough. So we are going to see about the chronic cough. Epidemiology of chronic cough, it affects 10 to 12% of population, more common in females, especially in 6th decade of life. The most common causes are asthma and its prototype, that is a phenotype, cough variant asthma, non-asthmatic eosinophilic bronchitis, GRD, upper airway cough syndrome, drugs. Drugs are more important cause we should keep in the background before going for detailed evaluation of chronic cough. The other causes we have to consider are disease of the airways, which include chronic bronchitis, especially in smokers, bronchitis, malignancy, foreign body, all that, and disease of the pulmonary parenchyma, which includes interstitial lung disease, lung abscess, and finally cough hypersensitivity syndrome and refractory chronic cough. These are the diagnosis of exclusion. And coming to asthma, so this is the leading cause of persistent cough in adults and most common cause in children. So present with chest tightness, wheezing, dyspnea, as we all know, and cough variant asthma, non-asthmatic eosinophilic bronchitis. These are the two things that goes unrecognized while evaluating for chronic cough. Since it present only with cough as the symptom, mostly it goes unrecognized. This cough variant asthma accounts for 10 to 40% of chronic cough. So the diagnostic criteria are present only cough as chronic cough as the symptom. There is an element of bronchial hyperresponsiveness. X-ray will be normal and patient classically responds to steroids. So it is, instead of detailed evaluation for this patients, we can start on empirical steroids and makes the diagnosis, retrospective diagnosis as cough variant asthma. And 30 to 40% of patients will develop classical asthma over a period of time. and diagnosis can be established with the help of spirometry, which can be normal or sometimes shows obstructive pattern. If it is normal, if further investigation is needed to confirm, can go for bronchoprovocation testing, but it's not available in majority of centers. And other supporting measures which can help in the diagnosis are sputum eosinophilia, which is more than 3%. That is more accurate when compared to evaluation in ball or blood. And fractional exhaled nitric oxide, that is elevated in most of the time. These are all only supportive markers to help to the diagnosis, not taken as a single parameter for the diagnosis of cough variant asthma. And coming to treatment of asthma and cough variant asthma, for patients presenting chronic cough as the symptom, we have to initiate steroids, low to medium dose inhalational steroid given for 2 to 4 weeks. At the end of 4 weeks, if the patient is not responding, then we have to escalate the dose of steroids, or we can add leukotriene receptor antagonist. And beta-2 agonist can also be added if patient is not responding. And if the patient is unresponsive to inhalational steroids, we can add oral steroids, 10 to 20 mg for 2 weeks can be given. Total duration of treatment is usually 8 to 10 weeks, that is 2 to 3 months or lifelong. Because if start weaning, patient developing the symptoms relapse, we can actually continue the treatment, or we have to do allergen testing, and we have to see if any allergic exposure or any occupational exposure that precipitating the patient for having symptoms. And coming to non-asthmatic eosinophilic bronchitis, this accounts for 7 to 33% of chronic cough. So the diagnostic criteria, as the name suggests, this is non-asthmatic eosinophilic bronchitis, which means that non-asthmatic, that is, there is no element of bronchial hyperresponsiveness. And eosinophilic bronchitis, once again, it's a eosinophilic inflammation of the airways. That is the diagnostic criteria. Only present as a chronic cough. Again, X-ray will be normal, PFT will be normal. There is no bronchial hyperresponsiveness here. When compared to asthma, cough variant asthma, this is the major differentiating factor. And eosinophilia, the sputum eosinophilia will be present, that is more than 3%, and again the patient will classically respond to steroids. Again, the treatment is same as that of asthma and cough variant asthma. The main difference of treatment here is beta agonist cannot be used here. This is because of difference in the pathogenesis. The mast cell infiltration will be maximum in asthma, that is followed by cough variant asthma. Here there will be minimum or almost nil mast cell infiltration, that is responsible for bronchial hyperresponsiveness, which in turn keep beta agonist as the treatment for this bronchial hyperresponsiveness. So as there is no muscle, there is no bronchial hyperresponsiveness, so there is no need of beta agonist here. That is the major difference of treatment here. And treatment again continued for 2 to 3 months. Mostly patients will respond. They do not need lifelong treatment. Next major cause is GRD related cough. So this prevalence varies widely, and the patient typically present with GRD symptoms like regurgitation, heartburn, hoarseness of voice, and dysphagia. And we have to keep in mind that 40% of patients, they remain asymptomatic. Even if the GRD symptoms are absent, they can have GRD related cough. So that is the thing which the problem in diagnosing GRD related cough and treatment also. That's why prevalence is difficult to measure for this GRD related cough. And mechanism of GRD related cough, there are two theories. One is reflex theory and another one is reflex theory. First one is there is stomach content get moves to the upper esophageal sphincter, that is larynx, and from there it aspirates the laryngopharynx and it goes to the lungs. So that leads to chemical pneumonitis, the stimulation of receptors in the lower airways, and also in the laryngopharynx, oropharynx, all that cough receptors get stimulated, that produces cough. Second one is reflex theory, that reflex theory is usual reflex we see. From stomach it goes to the lower esophagus, that is the usual reflex theory. This second reflex is mainly more important pathogenesis in GRD related cough. And coming to reflex cough cycle, the cough produces increased intra-abdominal tension in pressure, which precipitates GRD, which in turn again causes cough. This continues as a vicious cycle until it is broken by any lifestyle modification or drugs. And obesity and obstructive sleep apnea, these are the most important causes which predispose to GRD and causes chronic cough. And if the patients have GERD related symptoms or suspecting to have GERD related cough, then we can go for empirical treatment with starting with lifestyle modifications. Lifestyle modifications, we have to advise weight loss in overweight patients and head and elevation. We have to avoid caffeinated drinks and avoid smoking and alcohol, avoid having food just before bedtime, and all these things we can advise for lifestyle modifications. And drugs, the proton pump inhibitors are the drug of choice. We have to go for relatively high dose, 20 to 40 milligram omeprazole or equivalent twice a day, given for a period of 2 to 3 months. So we have to start with lifestyle modification and proton pump inhibitors. And if the proton pump inhibitors are actually, it produces only modest benefit. In patients having reflux also produces only modest benefit. So that is the problem in treating GERD related cough. Majority of time patients will not have symptomatic relief being treated. And once the patient is treated for 2 to 3 months, we have to assess the symptoms. If the patient is not relieved of symptoms of cough, then we have to go for extensive evaluation. This 24-hour ambulatory esophageal pH monitoring, that time we have to do, and multi-channel intraluminal impedance pH monitoring. This is the gold standard test for GERD related cough, since it has high sensitivity and specificity to diagnose, and also it has the capability, it can able to distinguish both acidic as well as non-acidic refluxes. So that is the gold standard. If facility is available, we can proceed for multi-channel intraluminal impedance pH monitoring, and we have to confirm the diagnosis and by doing this extensive investigation. And we have to go for, if the GERD related cough, again we are confirming at this stage, we have to intensify the treatment by doing PPA dose optimization, and we can add H2 receptor antagonist if still patient is not responding. And finally, if not responding, we have to add neuromodulators, that is which are the treatment of refractory cough, which will be discussed. And the role of prokinetics, this is according to ERS, BTS, all the guidelines. The prokinetics is not at all used in chronic cough. Actually, it provides no relief for the patients. Sometimes it's given the patient has any of the element of non-acidic reflux or esophageal dysmotility or any gastric emptying disorders. That time we can consider using this prokinetics. The only thing is it should not be used alone in treatment. It should be always combined with proton pump inhibitors or H2 antagonist. And drugs used are metoclopramide, domperidone, 10 mg orally TDS 30 minutes before meals. And final thing is surgery, laparoscopic or open Nissen's fundoplication in refractory patients cases when the patient is not responding to all of the discussed treatment modalities. Then upper airway, one thing about surgery is it should be recommended only to patients who have definitive evidence of reflux in investigation. Otherwise, for cough without any diagnostic confirmation, we should not proceed for surgery. Upper airway cough syndrome, so this is the third most important cause of chronic cough. So it's most often neglected. So we have to diagnose this by with the help of ENT surgeon. Also, we have to diagnose this category in the patient of chronic cough. This is due to presence of nasal secretions flowing to the nasopharynx, and the causes are allergic rhinitis, non-allergic rhinitis, vasomotor rhinitis, and rhinosinusitis. The exact mechanism of this syndrome in causing chronic cough is unclear. Probably it acts as a trigger for the sensitivity of the cough hypersensitivity syndrome. This is the explained concept as of now. And the clinical features: patient present with rhinorrhea, sneezing, postnasal drips, sensation, that is frequent throat clearing episodes will be there. On physical examination, patient will have excessive mucoid or purulent secretions, inflamed edematous nasal mucosa, polyps. If the patient has polyps, we have to rule out any associated eosinophilic inflammation of the airways, and secretions and cobblestone appearance. So this is more specific physical examination. Cobblestone appearance of the mucosa along the posterior pharyngeal wall. If clinically present, we can diagnose as upper airway cough syndrome and treat the patient. And chronic rhinosinusitis is diagnosed by the diagnostic criteria and treated with intranasal steroids and ipratropium or azilastine, saline irrigation, and antibiotics in case of chronic rhinosinusitis. And laryngeal dysfunction, this is the important component which is being given importance in ERS guidelines, that is otherwise called inducible laryngeal obstruction. So this is more important, that is functional inappropriate closure of the laryngeal inlet. The clinical features: patient present with cough and laryngospasm, which mimics asthma in sometimes. Diagnosis established by challenge laryngoscopy or specialized larynx CT protocol, which is available only in certain centers, because at rest time, most of the time, laryngoscopic finding will be normal, since the symptoms will produce only after exposure to the trigger factor. Treatment by physiotherapy, that is speech pathology and language therapy. Neuromodulators, if LPR is present, PPI can be used. Drug-induced cough, these are often more often neglected. Drugs causing cough are AC inhibitors, calcium channel blockers, bisphosphonates, latanoprost, that is used in glaucoma. So the patient, 5 to 30% patients taking AC inhibitors can have cough. This is mainly due to increased levels of bradykinin and substance P, which actually causes increased sensitivity of the cough reflex. If we stop the drug, cough resolves in 4 weeks to maximum 4 months, or sometimes some patients it will take 6 months also. Before going for a detailed evaluation of chronic cough, any drugs is there causing chronic cough, first we should stop the drug and observe whether the cough improves, and then we have to proceed for detailed evaluation. So that is more important for drug-induced cough. And cough hypersensitivity syndrome, so this is a syndrome that is given more importance in ERS guidelines and BTS guidelines also. So this here the patients have cough due very sub-threshold stimulus, like while the patient is eating, talking and having food, all the time patient will have cough, most common in females. So there is no specific diagnostic criteria. It is diagnosed by basically excluding all other treatable causes. This is cough hypersensitivity syndrome that is treated by, again, treatments the same as for refractory chronic cough. So assessment of cough, this is very important, because most of the time history taking, from history itself we can able to differentiate, come to differential diagnosis, and we can rule out other causes. We have to start with age and smoking history, chronic bronchitis and others we have to rule out in smokers, and past medical history, medications, occupational related exposure of symptoms, any preceding respiratory infection, because post bronchitic cough, that is the most important cause of chronic cough. Sometimes subacute cough can present as chronic cough, which post infectious bronchitis is one of the most important cause. Sputum production, if the productive cough patient, we have to rule out other bronchiectasis, lung abscess, all that, and triggers and timing of cough and associated symptoms as we have discussed above, and previous trials of therapy, if anything, we have to rule out. And this is the guidelines for evaluation of chronic cough. First we have to proceed with history and physical examination, and we have to identify the cough impact and triggers, family history and associated symptoms, as we are told, upper airway, lower airway, all the symptoms we have to assess, and we have to go for ENT examination, ear, nose, throat, and general examination we have to assess for patient clubbing, any signs of vasculitis, and we have to go for do cardiovascular, respiratory system examination, and look for organomegaly, lymphadenopathy, any signs of vasculitis, all that we have to look in general examination. Chest X-ray and PFT is basic for any patient presenting with chronic cough, and initial management, we have to stop the risk factors and initiate treatment, empirical treatment, mainly for upper airway syndrome and asthma, cough variant asthma, lower airway syndrome, and GRD. All the three things we can initiate empirical treatment, and we have to assess the treatment response after 3 months. If the patient is responding, we can continue the treatment. Again, if the patient is not responding, at this point of time, we need the detailed evaluation. We need the help of all the ENT surgeon, gastroenterologist, and other persons for to rule out this thing, that manometry and sputum, induced sputum test for AFB, all that we need. Methacholine challenge, chest CT, bronchoscopy. Routine use of chest CT is not recommended in chronic cough according to ERS and BTS guidelines. CT indicated only when the patient is a smoker, history of family history of malignancy, suspecting malignancy, any red flag signs like fever, weight loss, all that is in that time only chest CT is indicated. Otherwise, CT is not routinely used. Bronchoscopy also, if the patient has any abnormality in X-ray, CT, or foreign body inhalation suspected to have any localized finding in the auscultation, physical examination, that time bronchoscopy is needed. And treatment of refractory cough, so this is the, according to new guidelines, the OPH morphine is the drug of choice for the refractory cough. It's a low dose, 5 to 10 mg twice daily is used. Codeine is not preferred because of inter-individual variation in the metabolism. And next, gabapentin and pregabalin is less potent when compared to opiates, but that can be used next to if the opiates are contraindicated. And other drugs which can be used, non-specific antitussives are dextromethorphan, over-the-counter most common non-opiate agent, benzonatate, guaifenesin, nebulized lidocaine, all these are used, but they have a lot of adverse effects. They should be used carefully. Nebulized lidocaine have aspiration, tendency to cause aspiration because of oropharyngeal anesthesia. And non-pharmacologic intervention is recommended only in patients, those who are refractory to medical management, or as a sequential therapy for associated with drug treatment. Investigational approaches, these are the drugs which are under research phase, mainly phase 2, phase 3 trials, and gefapixant has been approved in other countries, P2X3 antagonist, but not available in India, and other P2X3 more selective drugs, sevoflurane, Camli, all are selective drugs, and NK1 antagonist, again trial phase, tapicon trial phase, M8 agonist, superior laryngeal nerve block, once again is under research phase, whether it could cause any treatment, whether it will be useful in refractory cough. Chronic cough in elderly, again there is a lot of problem. Already elderly patients have drug adverse effects, CNS problems, more comorbidities, which makes complications in further diagnosing and treating chronic cough. And research gaps, we still need, this is a vast topic, chronic cough, we still need more studies to identify the true prevalence, and assessment of chronic cough also needs further validated studies, and automated cough recording device need to be identified in real life technology, and practical biomarkers. We don't have any specific biomarkers as of now, so that need to be developed so that we can follow the guidelines protocol accordingly. That is the thing, and these are my references from which I have prepared this chronic cough management. Thank you.
Thank you, ma'am, for the wonderful talk.
The floor is now open for the discussion. Please feel free to ask any questions.
I invite Dr. Balakrishnan sir and Dr. K. Lavanya for discussion.
API Vellore District Branch through the Tapicon 2025 feels honored to honor our speakers. I request Dr. Kaniyan Pungundran to felicitate our first speaker, Dr. Balakrishnan of Pattukotai, with memento. Dr. Balamurugan from Narayani Hospital will felicitate the orator, Dr. Lavanya, on chronic cough. ஆமா என்ன பண்றது அப்படியே இருங்க request our organizing chairman, Dr. Sukumar ji, to felicitate Dr. Kaniyan Pungundran with memento. Thank you, Dr. Balakrishnan, Dr. Lavanya, for your good speakership, and thank you, Dr. Kaniyan Pungundran. Next session,
Announcement. The quiz program has been postponed to 5 o'clock at Pocus Hall.
Now we will pass on to the second session on rheumatology. We like to invite Dr. L. Muthumani, the talented physician and professor of medicine from Tiruchirappalli Medical College, to talk on the approach to polyarthralgia. In this session, we like to invite Dr. Kumaresan of Thiruvannamalai and Dr. Gopalakrishnan of Tiruvallur and Dr. Subramaniam of Tirunelveli.
இன்னைக்கு இது கால் இதுதான் டேவிட்சன் சுத்தமணி அப்ரோச் டு பாலி ஆத்திராலஜி.
டைமர் எங்கே வரும்? இல்லை டைமர் எனக்கு தெரியுமா?
ஃபுல்லாக பேடு தருவாங்க.
Really, polyarthralgia is a problematic one, and we think of many diseases, particularly even autoimmune, other common connective tissue disorders. Even then, you have to do the justifiable investigation as well as the timely intervention it needs. The guidelines are getting changed for earlier diagnosis and the classification, so it needs the detailed one and it's a right person, and it will be discussed by Dr. Muthumani. Over to you, sir.
Thank you, sir. Good afternoon, one and all. At the outset, I would like to thank the organizing committee, particularly Dr. Vetrivel sir, for giving me this opportunity. So the topic which I am going to take today is polyarthralgia. So it's a very big arena. It is very difficult to cover in a short period of time. So my talk will be restricted only to the clinical approach of polyarthralgia. That too, if you go into polyarthralgia, it is very difficult to handle it. So my talk will be more focused towards polyarthritis. That too, only a clinical approach, and I'm not going to touch anything regarding the investigation and management, all those things. Okay. So salutes to my professor and mentor, Professor M. Chennappan sir, and greetings from the ECG and Echo Club of Trichy. So musculoskeletal pains is one of the commonest symptom in the outpatient practice. More than 30 to 40% of our patient will come only with the non-specific musculoskeletal thing. So the idea is we have to find out among one of these things. Either it can be an arthritis, it can be a bone disorders, or it can be muscular pains, or very rarely it can be due to the psychological problems also. So the responsibility of the clinician is to first identify the area of origin of the pain and make a systematic and correct diagnosis. So if you fix the area of the origin of the pain, most often 50% of our problem will be over, because next we'll go for the investigation and management. So the challenge will rely more often where the pain is. So we have to get answer for where the pain is. So this is an approach. So we have to classify and we have to go through the 8 questions before approaching a patient coming with a polyarthralgia. Whether it is arthritis or arthralgia, whether it is articular or non-articular. If it is articular, it is polyarticular or monoarticular. Whether it is acute or chronic, it is inflammatory or non-inflammatory. Whether it involves small joints or large joints. Whether it is only upper limb or lower limb, or symmetric or asymmetric. So if we answer all the 8 questions, we can get into a sequence of things and we can fix the area of the origin, and most often we can get a reasonable good clinical diagnosis. So first thing is arthritis versus arthralgia. So the difference between arthralgia and arthritis is arthralgia is only pain. Arthritis means we will have the signs of inflammation. So the signs of inflammation are heat, redness, swelling, pain, and loss of function. So if only pain is present, that is called arthralgia. If any of the inflammatory signs is present along with pain, it is arthritis. So poly means 5 or more joints. So articular or non-articular. So this is the first thing which has got a great impact in the diagnosis of pain. So we have to first fix whether the pain comes from the joint or it is from the structures other than the joint. So which is called true arthritis. That is, these are the structures in the joint, the synovium, the synovial fluid, the joint capsule, the ligaments and the adjacent bones. So these include the articular thing. So if any of the structure is involved, it comes under the classification of arthritis. So the next thing is the periarticular or the non-articular. So these are the structures surrounding the joints like ligaments, tendons, entheses, bursae, muscle, fascia, bone, nerve and other things. So this is the first thing we have to differentiate whether the pain comes from the within the joint or outside the joint. So how to differentiate between articular and non-articular pain? So there are some clinical clues which you can get from the history. So in articular pain, the pain will be deep or diffuse, but in periarticular pain, it will be a localized, it will be very localized pain. The important thing is in articular pain, we will get pain both during active and passive movements, but in periarticular or non-articular pain, the pain will be only on the active movement. So this is one of the major differentiating features. But since there cannot be always and never in medicine, there are some exceptions also. So it is not an 100% rule, but most often if you go through this, you will most often will be right. So both passive and active movement will cause pain in articular pain, and only active movement patient will have pain in case of periarticular conditions. And other things in articular pains, you will get synovitis, effusion, crepitation, deformity and other things. And coming to the tenderness, you will have joint line tenderness in arthritis, but you will have a particular point of tenderness away from the joint in case of periarticular pain. So these are the things first to fix up whether the pain comes from the joint or from the structure surrounding the joint. And next thing is acute. Anything less than 6 weeks is acute. Anything more than 6 weeks is chronic. So these are few common causes of acute polyarthritis. So viral arthritis, reactive arthritis, enteropathic, polyarticular gout, acute rheumatic fever, and this RSP. RSP is remitting seronegative symmetric synovitis with pitting edema. So it is one of the paraneoplastic syndrome where you have multiple joint pains. And serum sickness. Serum sickness is a type 3 hypersensitive reaction where joint swelling and joint pain is one of the clinical features. And drug induced, there are some drugs like quinolones, minocycline, the aromatase inhibitors, interferon, diuretics, and all those things can cause the arthritis and arthralgia. And acute presentation of connective tissue disorders. Patient having an SLE, rheumatoid arthritis, psoriatic, all those things can have acute flare and they can also present with acute polyarthritis. And the causes for chronic polyarthritis are rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, osteoarthritis, juvenile idiopathic arthritis, and the adult onset Still's disease, sarcoid, brucella, soft tissue rheumatism, fibromyalgia, hypermobility syndrome, and connective tissue disorders. So the rheumatologists use a single thing that first thing is they will rule out the hypermobility syndrome after coming into diagnosis of polyarthralgia, because the persons like Marfan and other things who have hypermobility syndrome, they will mimic as polyarthralgia. So the presenting symptom will be pain in all the joints. So that is one important clinical clue we have to take into account. Next thing is how to differentiate between whether it is an inflammatory or non-inflammatory. So inflammatory means you will have the morning stiffness more than 60 minutes. Because of the rest, you will have all the accumulation of the fluid in the joint, so it can give pain. And the other signs of inflammation like redness, warmth, swelling and fever can be present. And the important clinical clue here is the pain will be worse after rest and better with activity. So you will be seeing in the spondyloarthritis and rheumatoid arthritis, where early morning when the patient gets up from bed, he will have severe pain, and after some time of activity, the pain will come down. So this is one important feature of inflammatory thing. So the same thing applies to the back pain. Whenever you are dealing with a patient with a back pain, the first thing is you have to differentiate between an inflammatory back pain and a mechanical back pain. The inflammatory back pain is when the pain when early morning when the patient gets pain and the pain gets better after activity. On the other hand, in non-inflammatory joints, there will not be no morning stiffness will be there, pain without signs of inflammation, and pain usually increases with activity. So this is the major difference to differentiate between inflammatory and non-inflammatory. So these are the conditions which can cause inflammatory arthritis, and the common cause for degenerative is osteoarthritis. So next thing is whether it is a small joint or large joint. So the predominant large joint involvement will be seen in spondyloarthritis, and the predominant small joint involvement will be seen in rheumatoid arthritis, and both small and large joints can involve in rheumatoid SLE, systemic sclerosis, psoriatic arthritis, and gout. So this is one major broad classification. And coming to symmetric and asymmetric, symmetric means both sides will be involved simultaneously. So symmetric, so rheumatoid arthritis, SLE, systemic sclerosis, and nodular osteoarthritis. Nodular osteoarthritis means the Bouchard and Heberden nodes. So these are symmetric presentation, and asymmetric will be spondyloarthritis and gout. But psoriatic arthritis is the only thing where it has both features of symmetric and asymmetric. So this is the how to differentiate between symmetric and asymmetric. Next, coming to the involvement of upper limbs and lower limbs. So hemochromatosis is only thing that we have seen in literature to involve predominantly in the upper limbs. For lower limbs, you can have gout and spondyloarthritis, but rheumatoid arthritis, SLE, and psoriatic arthritis have the predilection for both upper limbs and lower limbs. So this is one form of identification. And this temporal pattern is very important, whether it is migratory, whether it is additive or intermittent. So migratory means the prototype is the acute rheumatic fever. So one joint has inflammation, the joint recovers, and the next joint is involved. So this is called migratory. So the other causes of migratory are gonococcal, Lyme, sarcoid, infective endocarditis, and other things. The additive pattern is seen in rheumatoid arthritis, SLE, spondyloarthropathy, and osteoarthritis. And intermittent arthritis is seen in gout, CPPD, reactive arthritis, palindromic rheumatism, Beckett's, and other things. So this is one simple approach. So whenever you approach a joint pain, you have to go through these things. So the first one is what is the mode of onset, whether it is acute or chronic. Second is duration, what is the duration. And third is number of joints involved. And fourth is distribution of joint like symmetric, asymmetric, large, small joint like that. And fifth thing is sequence of involvement, whether it is a migratory or intermittent like that. And finally, extra-articular features. So there are extra-articular clues which can directly go into your diagnosis. So this is one sequence of involvement, so I don't want to go into detail of this. The only thing is in rheumatoid arthritis, the DAP is spared, and osteoarthritis, the wrist and metacarpophalangeal joints are spared. So this is the pattern of involvement in rheumatoid arthritis, osteoarthritis, and psoriatic arthritis. These are some important extra-articular manifestations where fever and hepatosplenomegaly, it can be in SLE, vasculitis, SLE, if there is nodules, rheumatoid arthritis and rheumatic fever, eyelash and Gottron papules, dermatomyositis, Raynaud's is in scleroderma, dry mouth, dry eyes, jaw grunts, and if there is any murmur, it can be due to bacterial endocarditis, and if there is any end-inspiratory crepitations, ILD, which can be caused by rheumatoid, SLE, and other things. So this is one simple approach, how to approach a patient with polyarthritis. First you have to identify whether it is articular or non-articular. If it is non-articular, the workup is different. If it is articular, it can be due to three things. Whether it can be a firm swelling, it can be a nodular swelling, or it can be a hard or bony swelling. If it is a hard or bony swelling, the diagnosis is straightforward. It is primary or secondary osteoarthritis. So if it is a nodular swelling, the diagnosis can be due to gout. But if it is a firm swelling, we have to further classify whether it is a symmetric involvement or asymmetric involvement. So if it is a symmetric involvement involving the small and large joint, you have to look into the duration. If the duration is more than 6 weeks, it can be due to chronic arthritis like rheumatoid, SLE, polymyositis, and systemic sclerosis. If it is symmetric and if it is less than 6 weeks, the first common diagnosis is viral arthritis, and other causes are hepatitis, rubella, sarcoid, serum sickness, and chikungunya. If it is an asymmetric arthritis, the common diagnosis is ankylosing spondylitis, Reiter's, psoriatic, and enteropathic arthritis. So this is the simple approach. First is articular or non-articular, second is consistency of the swelling, and third is symmetric or asymmetric. And one important thing is, if there is no synovitis or no involvement of the joint, you have to see for some tender points. If there is any tender points is present, the diagnosis is fibromyalgia, because it is one of the common differential diagnoses for polyarthralgia. If there are no tender points and no synovitis, but the patient has got a polyarthralgia, that is no arthritis, no tender points, only pain is present in multiple joints. These are the 7 differential diagnoses which you have to consider: viral arthralgia, vitamin D deficiency, hypothyroidism, diabetic cheroarthropathy, neuropathic pain, depression, or hypermobility syndrome. So the only take-home message that you want is this slide. So if there is no joint pain, no tender points, these 7 things you have to consider. So, and finally the takeaways, history gives a very vital clue, because you know the majority part of the rheumatology is based only on history. First confirm if it is true arthritis, classify based on the mode of onset, duration, distribution, temporal pattern, and extra-articular manifestations. Stepwise assessment and directed investigations is the primary goal. Once you get a clinical data and results of the investigations, apply criteria for making diagnosis, because a lot of criteria, Euler criteria and other criteria for all the arthritis, you can get the diagnosis, and correct diagnosis will lead to a specific treatment. And thank you for your patient listening.
Thank you, Dr. Muthumani.
Thank you, sir.
A very clear illustration and presentation, and useful for not only for the students as well as for the clinical practice. Useful message for the clinical
Thank you,
practitioner point of view. So the thing is, whenever there is the typical symptoms of arthritis, very easy to diagnose.
Yes, sir.
The problem is borderline between, that is what we call, there is arthralgia and arthritis.
Yes, sir.
That is a gray area for the physician to treat and manage. That is diagnose and manage.
Yes, sir.
So that area is still that thing, and very difficult for the sometimes for the physician to take the treatment.
Yes.
All
Thank
the
you, sir.
best.
Thank you, sir.
Thank you, sir. Now I invite Dr. N. Subramanian from Tirunelveli to kindly take the stage as chairperson. Next, we have Dr. K. Sivakumar from Coimbatore presenting autoimmunity mystery in medicine.
Yes, sir. Yes. Autoimmunity and autoimmune diseases really it has to be discussed. The autoimmunity, self-reactivity and injury cell to the tissues, how does it manifest? Really, when we talk about autoimmunity and autoimmune diseases, the treatment part of it and the outcome really where we are, and it has to be discussed, the chapter, the title, really. Over to Dr. Sivakumar, sir. Thank you, sir.
Thank you, sir. At the outset, I would like to congratulate and thank the organizing committee and scientific committee to give me this opportunity to talk in front of this elite audience. So the topic for me today is autoimmunity. Is it a mystery in medicine? So autoimmunity has remained an enigma for long years. The genetic and environmental background for the pathogenesis of autoimmune diseases has been elucidated only recently, and still research has been going on. And autoimmune diseases affect all the organs and all the systems from head to foot. And before a definitive diagnosis is made, the patients go to various specialists. They go to the orthopedician, they go to the dermatologist, they go to the pulmonologist before the final diagnosis is made. So I have chosen this topic. Autoimmune diseases, unlike other diseases, do not present their face overtly. The onset, course, and organ damage varies between individuals. The common features are presence of autoantibodies, persistent inflammation, and multisystem involvement. My focus will be on 5 major connective tissue disorders which affect young females mostly: SLE, Sjogren's, systemic sclerosis, inflammatory myopathies, and APLA. The term connective tissue disorders refers to a group of similar yet different multisystem diseases of autoimmune etiology common in women and characterized by presence of antinuclear antibodies. When should a clinician suspect presence of connective tissue disorders? Whenever there is multisystem involvement in women, like inflammatory polyarthritis, recurrent abortions, fever of unknown origin, polycirrhosis, mononeuritis multiplex, picture of ITP with splenomegaly, Reynolds phenomena, generalized lymphadenopathy, Zika symptoms, photosensitive rash, unexplained or a recurrent pulmonary and renal symptoms. First, we'll start with SLE. SLE is an autoimmune disease in which cells undergo damage mediated by tissue-binding autoantibodies and immune complexes. Increase in the immunogenic nucleic acids and self-antigens stimulate autoimmunity, thereby leading to increased production of autoantibodies. So the diagnosis is made by two criteria, the SLIC criteria and the EULAR criteria, which has both clinical manifestations and immunological manifestations. So the clinical manifestations are the most important is in the skin, the rash, the typical malar butterfly rash over the face, and the oral and nasal ulcers, and non-scarring alopecia. Then the synovitis, pleural effusion and pericardial effusion are characteristics, and renal involvement, synovitis involving more than 2 joints, and serositis, pleural effusion or pericardial effusion, and involvement of the kidneys and neurological manifestations. There will be also hematological manifestations, and thrombocytopenia is the most common hematological manifestation. Coming to the immunological manifestations, ANA should be positive. Then the specific ANA for SLE is anti-DS DNA and the Smith antigen, and APLA can be positive. APLA can be positive, and the serum complement level will be low, and the Coombs test will be positive. So the SLIC criteria requires more than 4 with at least 1 clinical and 1 immunological criteria. Coming to EULAR criteria, this also has the same constitutional criteria as well as immunological criteria, but it has a weighing score, and the highest score is for renal biopsy positive, and in immunological criteria, the highest score goes for SLE specific antibodies like Smith antigen and anti-DS DNA. So it requires a total score of more than 10. So with the above criteria, we can grade the disease as mild, moderate, and severe. And of all the 3 grades, the first line drug of choice is hydroxychloroquine. For the mild cases, along with HCQS, we can add oral steroids. And for moderate cases, azathioprine, CNA, or calcineurin inhibitors or mycophenolate mofetil can be given. And for severe cases, along with hydroxychloroquine, mycophenolate mofetil or cyclophosphamide can be given. If they do not respond to the above, then steroids are added, and for the mild cases, methotrexate is added. For the moderate cases, belimumab or mycophenolate mofetil, and for the severe cases, cyclosporin or rituximab is added. Next, coming to Sjogren's syndrome, mild or subclinical Sjogren's syndrome is the most common connective tissue disorder in clinical practice, far more than SLE. The classical triad of symptoms of Sjogren's comprises of dryness of the mouth and eyes, fatigue, and arthralgia. There will be extensive caries or reduced salivary pool in these patients. Hyperlobulation and fissuring of the tongue are characteristic changes associated with salivary hypofunction in patients with Sjogren's. So you can see in this picture the extensive caries due to hyposalivation. Dry eyes, dry mouth, parotid enlargement, and purpura is the spectrum of Sjogren's disease. So the systemic involvement in Sjogren's involves the interstitial lung disease. The commonest type is non-specific interstitial pneumonitis, kidney involvement as in tubular interstitial nephritis and distal renal tubular acidosis or peripheral neuropathy. The neurological disease may take the form of pure sensory neuropathy or mononeuritis multiplex. Hypokalemic periodic paralysis may be the first manifestation in many cases. And patients with Sjogren's syndrome are at increased risk of non-Hodgkin's lymphoma. Sometimes the mother may be totally asymptomatic, but the child, the fetus may have congenital heart block. That will be the first presentation and first time diagnosed cases. There are many instances like that. Incidental discovery by the fetal heart block. Then coming to investigations, Schirmer's test positivity is the filter paper. The filter paper wetting less than 5 millimeters in either eye shows a positive Schirmer's test, and minor salivary gland positivity is a sure diagnostic of Sjogren's. And the autoantibodies present in Sjogren's syndrome are ANA will be positive, rheumatoid factor will be positive, anti-Rho and anti-La antibodies will be positive. Coming to treatment of Sjogren's entails the use of muscarinic agonists like pilocarpine and cevimeline. And a meticulous dental hygiene should be impressed upon the patients. Brushing after every major meal, physical stimuli for salivation like sugar-free chewing gum and oral sprays help in the relief of oral symptoms. And eye dryness needs to be addressed by lubricating drops or punctal occlusion. Moisturizers are used for skin dryness, and women may need lubricants for vaginal dryness. HCQS is used in the arthralgias and purpura. Severe organ manifestations are treated with corticosteroids and immunosuppressive agents like methotrexate, mycophenolate mofetil, azathioprine, cyclophosphamide, or rituximab. Coming to systemic sclerosis, it is a rare disorder. It is characterized by fibrosis, vasculopathy, and immunological abnormalities. The fibrosis affects the skin, lungs, and the esophagus, and the vascular manifestations are Raynaud's phenomena, digital ulcers, pulmonary hypertension, and there will be renal involvement. So the antibodies which are positive in systemic sclerosis are anti-centromere antibodies, anti-topoisomerase antibodies, and anti-RNA antibodies. So systemic sclerosis has two types, limited cutaneous systemic sclerosis and diffuse cutaneous systemic sclerosis. In limited cutaneous, the skin thickening will be distal to the elbows and knees, and it may involve the face and neck, but the trunk is spared. Raynaud's phenomena predates the skin involvement by several years.
பேட்டரி இல்லாமல் அவ்வளோதான் இருக்குது சார்ஜர் அவ்வளோதான் இருக்கு. சொல்லுங்க விட்டு வர முடியாது அவன் யார் லாஸ்ட்
Sorry about that. So there are two types of systemic sclerosis, limited cutaneous and diffuse cutaneous. Diffuse cutaneous, the skin thickening extends proximal to the elbow and the knees, and truncal involvement is present. Raynaud's phenomena accompanies or comes up within a year of onset of skin changes, and there will be pulmonary, renal, and gastrointestinal involvement. In limited cutaneous systemic sclerosis, the autoantibodies which are positive are anti-centromere antibodies, and in diffuse cutaneous systemic sclerosis, the autoantibodies are anti-topoisomerase and anti-RNA polymerase antibodies. So the typical features in systemic sclerosis are characterized by tight, shiny skin, loss of wrinkles and expressionless face due to reduced mobility of the eyelids, cheek and mouth, microstomia due to reduced oral aperture interfering with eating and oral hygiene, nose presence with a beak-like pinched appearance, and in the late stage the skin becomes thin, atrophic and tethered to the subcutaneous fat. So the characteristic feature is called mask of appearance. Treatment, the mainstay of drug treatment for Raynaud's phenomena is calcium channel blockers like nifedipine. For GRD, we give proton pump inhibitors like omeprazole and pantoprazole. For esophageal dysmotility, prokinetics like domperidone, mosapride and atopipride are used, and along with immunomodulators, steroids and immunosuppressants. So next, coming to idiopathic inflammatory myopathies. These are a heterogeneous group of disorders characterized by symmetric proximal muscle weakness caused by inflammation of skeletal muscles. There are 4 subtypes: dermatomyositis, polymyositis, inclusion body myositis, and immune-mediated necrotizing myositis. Dermatomyositis and polymyositis are the most common subtypes. Females are more affected in dermatomyositis and polymyositis, whereas males are more affected in inclusion body myositis. Patients often present with insidious onset of proximal muscle weakness, typically of the neck, shoulders, thigh and pelvic area. Dermatomyositis and polymyositis may overlap with other connective tissue disorders like SLE and scleroderma. Inflammatory myositis are associated with systemic involvement such as arthralgia, interstitial lung diseases, cardiac, gastrointestinal and renal involvement. Dermatomyositis is associated with increased incidence of malignancies, and prolonged use of statins is associated with immune-mediated necrotizing myositis. So this is a typical rash around the eyes called resembling the heliotrope flower, and the Gauthren's papules found in the extensor surface of the hands, more common in the proximal interphalangeal joints. The investigations, the enzymes CPKMB, LDH, AST and ALT will be raised. The autoantibodies positive in myositis are anti-MI2, anti-SAE, anti-MDAS, anti-NXP2, anti-TFI gamma and anti-IRS antibodies. So the treatment is high-dose steroids, methotrexate, mycophenolate mofetil, calcineurin inhibitors like cyclosporin and tacrolimus, cyclophosphamide, biological agents like rituximab, tocilizumab, abatacept and anankera, and IVIG. Next, lastly, coming to antiphospholipid antibody syndrome. So this is a systemic autoimmune disease characterized by antiphospholipid antibodies, clinically by recurrent venous or arterial thrombosis and late pregnancy loss. The APS may exist in isolation without any definable association, whereas when it is called as primary APS, or when it is associated with other autoimmune diseases, it is called as secondary APS. So the triad is presence of APL antibodies, pregnancy loss and thrombosis, both arterial and venous. The clinical recognition. A clinician should suspect antiphospholipid syndrome in the following situation. Thrombosis at a relatively early age, that is male less than 55 years or female less than 65 years. Thrombosis in the absence of known risk factors or recurrent thrombosis. This may take the form of deep vein thrombosis, pulmonary embolism, myocardial infarction, stroke or digital gangrene. Recurrent pregnancy loss or premature birth will be present. The recurrent pregnancy loss, the abortion usually will be in the last trimester. And presence of valvular vegetation should arise the suspicion. And thrombocytopenia or hemolytic anemia are the hematological manifestations. Non-thrombotic neurological symptoms like migraine, chorea, seizures, Guillain-Barré syndrome or transverse myelitis can be present. And whenever there is unexplained adrenal insufficiency, osteonecrosis, nephropathy or pulmonary hypertension, this should arise the suspicion of antiphospholipid syndrome. So the clinical features are from head to foot. And the most common features are DVT, which occurs in 32% of the patients. Thrombocytopenia occurs in 22% of the patients. Libido reticularis we cannot see clearly in our group of patients. Stroke is present in 13% of the patient. Superficial thrombophlebitis is seen in 9%. Pulmonary embolism is seen in 9%. Fetal loss is seen in 8%, and transient ischemic attacks in 7%. So this is the criteria for diagnosis of antiphospholipid syndrome, which has clinical criteria, that is vascular thrombosis and pregnancy loss, and the lab-based criteria, that is we have 3 autoantibodies, beta-2 glycoprotein antibody, lupus anticoagulant and anticardiolipin antibody. More than one antibody should be present on 2 occasions 12 weeks apart to make the diagnosis of APS. Coming to treatment, APS without thrombotic event, primary prevention with low-dose aspirin will do. Thrombotic APS requires full anticoagulation with intravenous or subcutaneous heparin followed by warfarin. Low molecular weight heparin is preferred to unfractionated heparin here. In unprovoked venous thrombosis, recurrent thrombosis and arterial thrombosis, the treatment is lifelong. Then coming to catastrophic APS, this is best managed by using a combination of steroids, heparin and plasma exchange or IVIG. This will be usually associated with infections which need appropriate antibiotics, and other agents tried in refractory CAPS are beta cell depletion therapies like rituximab or complement inhibition therapies like isilsumab. And despite treatment, the mortality is very high in these patients. So coming to the conclusion, the above 5 connective tissue disorders affect young females predominantly. Often they are diagnosed in the late stages after multiple abortions or after end organ damages, thereby having a devastating effect on their academic, professional and reproductive life. The toxicity of the disease-modifying agents and the drugs used in the treatment of flares is of major concern. Therefore, early identification and treatment will prevent flares and stabilize the immune system so that the disease sits lightly on these young, unfortunate patients. Thank you.
Thank you, Dr. Sokumar. CTD is a tough topic, but you have covered in 15 minutes. So just 2 points for the PG sake. If somebody has ITP, think about lupus. Somebody has hypothyroidism in a young woman, think about lupus, because there may be a connection between ITP, Hashimoto's thyroiditis, and also lymph nodes. So if you have fever, lymphadenopathy, and these symptoms, think about it. And if you have a Raynaud's in a teenage group, also think about lupus. It's only the thinking thought process, then only you can pick up early. As sir was saying, if you pick up early, it's good for controlling the disease early on. Just differ about the toxicity. We don't, as a rheumatologist, the drugs are very safe in these patients. Only we have to be cautious in managing the patient with their family discussion, because it's a women, young women affected, and the family has to be supportive, and they should continue the treatment of rheumatology rather than going for the native treatment. That is the hard point here to manage the patient. Thank you, sir. Thank you. So questions at the end of it, yes? Yes, thank you. Next, I invite Dr. Raja, who is a consultant rheumatologist at Naruvi Hospitals. He's trained in our premier Institute of Rheumatology in Chennai for rheumatology. He's also well known in APA circles and a colleague of my team. Over to Dr. Raja for talking about vasculitis. You may be seeing in Hindu, there is a wellness series going on every week in different specialties from Naruvi and Hindus. So he's also one of the main person in that. Welcome, Dr. Raja.
Thank you. So the primary purpose of the talk is to just create sensitized awareness that there is something vasculitis is there, and vasculitis we see in daily practice, and many times we miss it. Okay. So for the purpose of understanding of vasculitis, we must know which vessel is involved. So there are 3 classifications of vessels: large, medium, and small vessels. Large vessels means aorta and its major branches. Medium means the main visceral artery, like your splenic artery, hepatic artery, all the medium vessels. And small vessels means intraparenchymal arteries, arterioles, capillaries, veins, and venules. So you have to understand that there are 3 types of vessels: large, medium, and small. And based on the vessel involved, the classification changes. What are large vessel vasculitis, medium vessel, and small vessel? We will be seeing each of this, only highlighting only very few important features of each vasculitis. So large vessel vasculitis are giant cell and Takayasu. Medium vessel vasculitis is polyarteritis nodosa and Kawasaki. And small vessel vasculitis, the classification its own. And again, I would like to stress the fact that even though the names look very weird, we are seeing all these patients in daily practice, and actually we are not picking up because of lack of awareness about it. There are some signs when to suspect vasculitis. When you see a patient in clinical practice, in medicine ward or internal medicine emergency, there are typical signs of large vessel vasculitis are limb claudication, asymmetrical blood pressure recordings, absence of pulse, Bruy aortic dilatation. That's why we ask the patient to look at pulse of all 4 limbs, BP of all 4 limbs, auscultating of all vessels. All those will pick up large vessel vasculitis. Medium vessel vasculitis, there are some specific signs. So these are the signs of medium vessel vasculitis: nodules, ulcers, livido reticularis, gangrene, mononeuritis multiplex, microaneurysms, Some of the images, see this is the livedo reticularis, then there are nodules, non-healing ulcers in the leg, gangrene in the digits. These are all the evidence that the medium vessels are involved. Small vessel vasculitis, see these are the evidence of small vessel vasculitis. You see purpura, you have petechiae, you have splinter hemorrhages. Just going to the previous slide. Alveolar hemorrhage, diffuse alveolar hemorrhage in the lung. All these are evidence of small vessel vasculitis. So based on this, now you know the diseases. I've already told you large, medium and small vessel. A brief introduction of each of the vasculitis so that you know what we are dealing with. I'm just skipping because this is the classification of vasculitis which is available online. So when to suspect vasculitis? That is a primary question here at the general physician level and at the specialist level. For that you must know the vasculitis. So the two common large vessel vasculitis are giant cell arteritis and Takayasu arteritis. Giant cell arteritis is going to basically involve the aorta and its major branches with a predilection for carotid and vertebral arteries. The commonest presentation of giant cell arteritis which we see in clinical practice is an elderly male presenting with unilateral headache, fever and a high ESR. The temporal artery is involved, you pick up temporal arteritis. That is the commonest presentation of giant cell arteritis, but we have to understand that it is not a rule that every time only temporal artery should be involved. Any large artery can be involved, even axillary artery, brachial artery, any artery can be involved. So whenever an elderly patient presents with fever, with high ESR, you have to suspect a large vessel vasculitis, especially giant cell vasculitis, giant cell arteritis. If they also have headache and associated temporal artery involvement, it all the more substantiates the diagnosis. So other common large vessel vasculitis is Takayasu arteritis, which is we see commonly in medicine ward. Young female presenting with a stroke, young female presenting with sudden onset vision loss, and young hypertension. So whenever you see a young hypertension in a medical ward, one of the differential diagnoses is Takayasu arteritis, because there can be renal vessel involvement that can cause renal artery stenosis and hypertension. They can have involvement of the aorta. So again, it's a granulomatous arteritis, predominantly affecting aorta. Onset usually seen in patients younger than 50. Usually young patients, it's seen in women as well as men, but more common in women. And it is common in Asia. In Asian population, Takayasu arteritis is actually the type 5 Takayasu is more common, where there is extensive involvement of the entire vessels from the thorax to the abdominal renal vessels. So when you do a conventional angiography, they are able to pick up in the vessels, the aorta, they see whether it is involvement in the renal vessel is involved, pre-renal or below the renal vessels or above the renal vessels, celiac artery is involved, mesenteric is involved, whether the arch of aorta is involved, and based on that, the Takayasu arteritis has got a classification 1, 2, 3, 4, 5. It's a new angiographic classification. I don't want to go into detail, but presence of type 4 and type 5 indicates that abdominal vessels are also involved. Type 5 is involvement of the ascending aorta, aortic arch as well as the renal vessels. So the two large vessel vasculitis you've seen. The medium vessel vasculitis, there are only two medium vessel vasculitis, polyarteritis nodosa and Kawasaki disease. Polyarteritis nodosa is a necrotizing vasculitis of usually medium size. The point here is there is no small vessel involvement. So meaning that you will not have glomerulonephritis. There will be no microscopic hematuria in the kidney. There will be no diffuse alveolar hemorrhage in the lungs because they are all small vessel involvement. And there is no ANCA positivity. So usually the typical picture of polyarteritis nodosa is again abdominal pain, weight loss, testicular pain. They can have mononeuritis multiplex. Based on that we diagnose. So they have a beaded appearance. You do abdominal imaging, you look at narrowing and aneurysms of the abdominal vessels in angiogram. Kawasaki disease usually seen by pediatricians. Sometimes we also see when the young child. We have a classification criteria for Kawasaki disease also. So basically here it is a vasculitis associated with mucocutaneous lymph node syndrome, enlargement of lymph nodes, conjunctivitis, desquamation of the skins of the hands and feet. Again, it's a predominant medium vessel vasculitis. The only problem here is coronary artery involvement can be there. So they can cause coronary artery aneurysms, they can cause, there may be thrombosis of the coronary vessels. So here you should have early use of intravenous immunoglobulin to prevent the occurrence of coronary aneurysms. So these are some of the images of coronary aneurysms. So again coming to the small vessel, these are very commonly seen. I think the topic is so huge, I will just mention it. Microscopic polyangiitis is a small vessel vasculitis involving lung and kidney. Whenever you have diffuse alveolar hemorrhage, you have a rapidly progressive renal failure, glomerulonephritis, suspect microscopic polyangiitis. This is vaginous previously, now we call it as granulomatosis with polyangiitis. This we see, this is one of the common ANCA vasculitis which we see in clinical practice. Here there is necrotizing granulomatous inflammation of the upper and lower respiratory tract. In the upper airways you have destruction of the nasal cavity. In the lower respiratory tract you have cavities, nodules in the pulmonary vessels, and there is also glomerulonephritis and other vasculitis of the other organs also involved. So these are the strawberry gums which is feature of vaginous granulomatosis. And another form of ANCA vasculitis, small vessel vasculitis, is Chuck-Strauss syndrome, eosinophilic granulomatosis with polyangiitis. Here, the patient will have asthma, polyposis, sinusitis, and later they develop vasculitis. Again, there are so many types here. Some people can have cardiomyopathy, peripheral neuropathy, they can have renal involvement, they can have peripheral neuropathy. Another type of vasculitis is anti-GBM disease. This is again a small vessel vasculitis. Again, this is going to cause renopulmonary syndrome. They will have a diffuse alveolar hemorrhage in the lungs and rapidly progressive renal failure. Another type of vasculitis is cryoglobulinic vasculitis, where the patient will have small vessel vasculitic features, palpable purpura, petechia. They will have associated neuropathy. They can have skin involvement with non-healing ulcers, and they are associated with the presence of serum cryoglobulins. The problem here, the point is, every disease will be the same only. When you see the clinical picture, almost all diseases, whatever I am repeating the same only. They can involve skin, lung, kidney. So how to differentiate it is the problem here. Almost all of the vasculitis will fit into any one of the pattern. Either they will involve large vessel, they will involve medium vessel, or they will involve small vessel. So it's very difficult to, only the investigations can prove it. And another common problem is Henoch-Schönlein purpura, nowadays called as IgA vasculitis, which most of us see in clinical practice. Upper respiratory infection, children or adolescent people, few weeks later they are going to present with involvement of joints, skin and gastrointestinal tract. They will have lower limb arthritis, purpura in the skin and gastrointestinal tract involvement. And some people can have glomerulonephritis, which can be persistent also. It's a palpable purpura can occur. Another type of thing is hypocomplementinemic urticarial vasculitis. Vasculitis is accompanied by urticaria and low serum complements. It affects small vessels and is associated with anti-C1q antibodies. They can have associated arthritis, eye disease and obstructive pulmonary disease. Behçet disease is one disease where you have large, medium and small vessel. Any vessel can be involved. That's a variable vessel vasculitis. The patient will have recurrent oral ulcers, genital ulcers, eye lesions, skin lesions, pathology test will be positive. They can have thrombosis. So these are all not very common diseases. That's why we do not have enough data on this. It's not like rheumatoid arthritis, where the previous speaker spoke nicely on rheumatoid arthritis or ankylosing spondylitis, where there are specific lot of guidelines and lot of cases. These are all vasculitis which you have to pick up based on the awareness only. This is called as the thromboangiitis. You have oral ulcers, genital ulcers, you have eye lesions, skin lesions. Behçet disease we see at least once or one or two patients in a month. Cogan's I will be skipping. So again another type of vasculitis, single organ vessel involvement. Only one organ is involved. Some people will have only non-healing ulcers, which we commonly see in clinical practice. No varicose vein, no arterial lesions, non-smoker, nothing else. But they'll have a non-healing ulcer, you do a biopsy, you pick up vasculitis. That is single organ cutaneous vasculitis. They'll have cutaneous polyarthritis is there. Another common thing is primary CNS vasculitis, where you have fever, headache, cognitive dysfunction, seizures, and I don't think fever is there, but headache, cognitive dysfunction, seizures, that's a feature of primary CNS vasculitis. So these are all single organ vasculitis. And SLE patient can have vasculitis, rheumatoid patient can have vasculitis, sarcoidosis patient can have vasculitis. A rheumatoid patient with a big non-healing ulcer in the leg is a medium vessel vasculitis. SLE patient with purpura in the legs is a small vessel vasculitis. So again think. Hepatitis C can have cryoglobulinic vasculitis. Hepatitis B can have polyarthritis nodosa. Syphilis can have. Drug-associated vasculitis is there. So it's a huge spectrum. So maybe the last few slides, what I want to convey to the people here. No. So with so many vasculitis here, it is not practically possible at the first time to see and tell this is the name of the vasculitis. Our duty as a physician is to suspect vasculitis in this patient. So when a neurologist suspects a vasculitis, when he sees, or a general physician, new onset headache in elderly, you have to remember, it's not a migraine or tension headache which is going to start in the young. New onset headache in the elderly, suspect giant cell arteritis. Stroke in a young patient, Takayasu arteritis, we already discussed. Unexplained multiple cranial nerve palsies, a probability of vasculitis is there. Mononeuritis multiplex, simultaneous or sequential involvement of non-contiguous nerves is a very definitive indicator that it's a vasculitis. Unexplained neuropathies, unexplained triad of headache, seizures and cognitive dysfunction could be primary CNS vasculitis. So that is important. I just thinking, so whenever there is mononeuritis multiplex, it is a sign of medium vessel vasculitis. The differential diagnosis for mononeuritis multiplex is PAN, ANCA vasculitis, cryoglobulin vasculitis, SLE or Sjogren's associated vasculitis, infections and medical conditions like diabetes amyloidosis. Just looking at specialists, when as a respiratory medicine person, when he encounters unexplained cavitating nodules or diffuse infiltrates in the lungs, unexplained nodules, vaginous granulomatosis, diffuse infiltrates could be vaginous or Church-Strauss syndrome. Adult onset asthma is a Church-Strauss syndrome. Diffuse alveolar hemorrhage is a definitive indication there is a vasculitis. And pulmonary artery aneurysms, Behçet disease and Takayasu arteritis can have. So these are non-cavitating nodules, so which is a feature of vaginous granulomatosis. Again, when in the ward we see a diffuse alveolar hemorrhage, the differential diagnosis is very clear. ANCA vasculitis, vaginous, microscopic polyangiitis, anti-GBM disease, lupus, cryoglobulic vasculitis. All are definitive evidence of thing. And as a nephrologist, you suspect whenever you have active urinary sediment, whenever there is a rapidly progressive renal failure, background should think of, other than the glomerulonephritis part, ANCA, SLE, all those are features of anti-GBM disease. Proteinuria, you suspect vasculitis. So progressive RPRF is one of the common differential diagnoses. GPA, MPA, anti-GBM disease and HSP and cryoglobulic vasculitis can occur. As a dermatologist, the first point of contact is many times the dermatologist who see a patient with vasculitis. We already discussed small vessel has got some features, medial vessel has features. So dermatologists frequently encounters. So whenever there is a palpable purpura, it indicates that there is vasculitis, no doubt. Palpable purpura is a definitive indicator of vasculitis. No systemic involvement, then it is only cutaneous, single organ, leukocytoclastic vasculitis. Other differential diagnosis, HSPA, cryoglobulic vasculitis, CTD, all other things can occur. And even Takayasu arteritis, even though it's a large vessel vasculitis, can sometimes present with palpable purpura. A ENT specialty will also encounter a lot of vasculitis. Vaginous granulomatosis, that is GPA, can have nasal pain with bloody nasal discharge, extensive nasal crusting. The Church-Strauss syndrome, EGPA, can have sinusitis, asthma, eosinophilia. Just 3 or 4 slides more. So this is the destruction of the sinuses which occurs with vaginous, how bad the destruction is. So the cavity is disturbed. I was reading one of the differential diagnoses, even cocaine-induced upper airway destruction is the differential diagnosis of vaginous granulomatosis, especially in European population. There are some differential subtle features which there is finding can be found out. Cardiologists can encounter. As I already told you, Church-Strauss syndrome can have cardiomyopathy. Kawasaki disease can have coronary aneurysm. And coronary artery vasculitis is also there. Ophthalmologists can encounter vasculitis. Sudden onset visual loss, giant cell arteritis, sudden onset temporal artery involvement and ophthalmic artery involvement. Takayasu arteritis can have sudden onset visual loss. SLE can have retinal vasculitis. Vaginous granulomatosis can involve progressive vision loss with ophthalmoplegia. And again, they can have scleritis. Behçet can have uveitis. The point we're trying to tell is some pictures. Gastroenterologist, polyarteritis nodosa can have diffuse postprandial abdominal pain. Could be evidence of mesenterial vasculitis. Henoch-Chandlin purpura can have abdominal pain with rash and arthritis. Even SLE can have vasculitis of involvement. Absent pulse, suspect Takayasu. Asymmetrical BP recording, suspect Takayasu. Accidental bruit, suspect Takayasu. Hypertension, Takayasu. Vasculitis with renal involvement. Pyrexia of unknown origin is a common differential diagnosis for many of the vasculitis. So the last slide which I want to tell is, any organ can be involved in vasculitis. What we have to understand is a strong index of suspicion is needed. What we can do is see which vessel is involved, large, medium or small. Based on that, put a differential diagnosis for large, medium and for small. And in that you can do workup. There you have a lot of serological tests, biopsy is there, ANCA testing is there. That may take a long time but beyond scope. So the take-home message is, whenever you see a palpable purpura, whenever you see a mononeuritis multiplex, renal-pulmonary syndrome, that is lung hemorrhage with glomerulonephritis, diffuse cellular hemorrhage, and multisystem involvement with significant constitutional symptoms, always suspect vasculitis, and vasculitis is there and it is very much there. So May is the vasculitis awareness month. So maybe we should try to do some program. Thank you.
Thank you very much, Dr. Raja. What was discussed in any textbook, very wide and difficult to consume it. You have made it very simple, sir, particularly for PGs. Really, it's useful, and with a particularly to say what's a specialist has to do it, has to think towards the vasculitis. Whenever a multi-system involvement, you have to think of vasculitis, whatever at the end, undiagnosed, whatever it may be. But as a specialist cardiologist, pulmonologist, really I appreciate and thank you very much once again.
Thank you. Dr. Raja has clearly mentioned about the primary vasculitis, but what we see as a physicians is also a secondary cause of vasculitis, which is a different topic. But it's a nice summary, and I hope it helps the PGs. Thank you. With that, we conclude this session, and thanks organizers. Any questions from the audience to all the three speakers? Is Dr. Muttumani, Dr. Sivakumar, and Dr. Raja. Please. So we invite all the three speakers, Dr. Muttumani, Dr. Sivakumar, and Dr. Raja, to the stage. And any questions to them? I'm sure there'll be more questions. Okay. If not, we'll thank the organizers for giving us the opportunity to share the session. I will hand over to Dr. Vetrivel, sir.
Good evening, friends. Greetings from Tapicon 2025. It's very honored to honor our speakers, Dr. Muttumani, to be honored by Dr. N. Subramaniam sir from Tirunelveli. Dr. Balakrishnan to be honored by Dr. Kumaresan sir. Sorry, Dr. Sivakumar to be is honored by Dr. Kumaresan sir. It's a time to honor our long-lasting associate, Dr. Raja, the senior rheumatologist from Narivi Hospital. He is always regular in motivating and attending our APA proceedings. This time, Tapicon 25, through Vellore District Branch, honors our Dr. Raja through Dr. Gopalakrishnan of Tiruvallur. I request Dr. Manigandan sir to honor our chairperson, Dr. Kumaresan sir, through this memento. I request Dr. Raja to honor Dr. Gopalakrishnan of Tiruvallur. I request our astute clinician from Trichinopalli, Dr. L. Muthumani, to honor our brother, elder brother, Dr. Subramaniam. Thank you very much, both the speakers and chairperson, sir. It's a time to move on to the twin orations. I request Dr. Sukumarji, the organizing chairman, to chair the session, and yet another stalwart from Coimbatore, Dr. Balamurugan, to chair the session of these orations. I'll request Dr. Gunasegar to read the citation of Dr. Parandaman, sir. The first oration is Dr. Vishwanathan oration, earlier recognition of hyponatremia in clinical practice. It is to be none other than the vastly talked among physician circle and earnest and talented teacher, Dr. Parandaman sir, is going to do this oration. I request Dr. Gunasekhar to do the formalities.
Good evening to all. Association of Physicians of India, Tamil Nadu State Chapter, Dr. M. Viswanathan oration. This prestigious oration was instituted in recognition of Professor Dr. M. Viswanathan, who came from Irinjakuda in Kerala to Chennai to study medicine at Stanley Medical College, and is considered as the father of diabetology in India. He set up India's first center for diabetes, MB Hospital for Diabetes, in 1954. Under his professional and administrative leadership, this hospital has acquired the status of teaching institution of international excellence. The Association of Physicians of India, Tamil Nadu State Chapter, is pleased to award the Professor Dr. M. Viswanathan Oration Award 2025 to Dr. P. Parandaman, MBBS, DTCD, MD, FICP, FIMSA, FRCP, and FSCP. Dr. P. Parandaman studied MBBS from Kilpack Medical College in the year 1988 and DTCD from Institute of Thoracic Medicine, Madras Medical College, Chennai in 1992, MD General Medicine from Government Stanley Medical College in 1997, and postgraduate diploma in Health Sciences in Diabetology in 2005, and Master of Health Sciences in Diabetology in 2010, currently working as a senior consultant physician and academic head, Sugam Hospital, Ambattur, Chennai, and honorary postgraduate teaching faculty for Southern Railway Hospital, Perambur, Chennai. Dr. Parandaman is a fellow of Indian College of Physicians, fellow of International Medical Sciences Academy, fellow of Royal College of Physicians, Glasgow, fellow of American College of Physicians, FACB. He published more than 20 articles in the peer-reviewed national journals and 5 are original articles. He is the chief editor of Manual of Toxicology in Indian Perspective. He is a member of Board of Studies for undergraduates and postgraduate students at Dr. MGR Medical University and Vice Chairman, Tamil Nadu State Chapter during the year 2019 to 24, and Joint Secretary of Association of Physicians of India, Chennai branch since January 2025. Dr. P. Parandaman is a life member of Association of Physicians of India, life member and executive committee member of API Tamil Nadu State Chapter, life member of Association of Physicians of India, Chennai City Branch, member of Indian Society of Critical Care Medicine, life member of National and Tamil Nadu RSSDI, life member of Nuclear Cardiological Society of India, and member of Hypertension Society of India. Dr. P. Parandaman received Talented Physician Award by the City Physicians Association during the year 2001 and Certificate of Merit awarded for the meritorious service during the year 2011, 13, 16, 17, 20, 21, 23 and 24 by the Dean, Kilpack Medical College. Best Doctor Award from District Collector Thiruvarur on Independence Day in 2014 and Teacher for Excellence Award at Tapicon at Salem. award from Honorable Health Minister of Government of Tamil Nadu for the proactive management of COVID in the pandemic year. The Association of Physicians of India Tamil Nadu State Chapter takes immense pleasure and honor to award the prestigious Dr. M. Viswanathan Varation to Dr. P. Parandaman at the 21st Annual Conference of APA Tamil Nadu State Chapter Tapicon 2025 at CMC Vellore. Thank you.
Thank you very much, sir, for having bestowed this a great honor on me, Professor M. Viswanathan sir Oration. I am really indebted to all the organizing committee members, State Secretary, Dr. Gunasegaran sir, Chairman Organizing Secretary Sukumar sir, Scientific Committee Chair, Dr. Vettivel sir, and Dr. Satish sir for having given me this wonderful opportunity to receive this honorarium. Thank you very much. I'll be talking about this oration. The topic is the early recognition of hyponatremia. Hyponatremia is very common electrolyte abnormality, what you see in day-to-day practice. Not only common, it is common in this season, summer season. Common in elderly. Is a complicated problem in diabetes and other comorbids than other individuals. So, if we see the hyponatremia, most of the time we diagnose it late. The reason is the symptoms are non-specific. So no one suspects hyponatremia. Any person comes with tiredness, decreased food intake, decreased appetite, body pain, headache. Definitely no one suspects hyponatremia. Probably attribute to the function, works or the thing, or sleeplessness, all these things. But by the time they present to the hospital with a seizure, altered sensorium is already complicated. So, within mind, I'll go to the first case, presentation. This is the first year, I present my talk in two parts. One, challenges in managing the cases, and two, solution for the challenges. This is 41-year-old male, and is an advocate by profession, came with abdominal pain, giddiness, tiredness, anorexia, and decreased food intake of 2 weeks duration. And with the history of seizure, he got admitted. On admission, vitals were stable. The sodium was 112. Almost all other parameters are normal. He had a fever at the time of admission. Patient was evaluated for fever, found to be E. coli positive in the urine culture. Total count is elevated. So it is a UTI clear-cut, hyponatremia clear-cut. Young male present with the symptoms, we treated this patient. Patient completely all right, but anemia was on top of it. So we wanted to work out whether is there anything other than the UTI causing the problem. So, we have treated, hyponatremia corrected, fever all right. Now patient question is, sir, what is the cause for the problem? Will it get again? So because hemoglobin was low, we thought of doing a panel also for the immunological panel to rule out immune-mediated destruction, endoscopy, colonoscopy to rule out malignancy in GIT causing anemia. So all were there, but everything was normal. Finally, what happened? We could not find out the cause. Then we could get the history from the patient's wife. That patient was stressed for last 1 month. He was advocate. He lost the case. So he was going to Madurai every alternate days. When traveling to every alternate days, it takes 2 cans of water, 2-liter can, 4 liter on and 4 liter return, 8 liters per day with in addition 2 liters while taking food. So totally 10 liters of water he was taking every day, every alternate days when he was traveling. And with the stress, he has developed hyponatremia. Stress inhibits the release of ADH and the hyponatremia secondary to water, so dilution hyponatremia is only nothing but a that is dilution hyponatremia. No other cause was found. Patient is all right. Perfect is coming for the past 6 months. There is no issue at all. What is the lesson learned? Is there is psychogenic polydipsia is commonly missed. The history only made the diagnosis. If you have not taken the history, probably you have missed the diagnosis. This is a case number 2. This is an 88-year-old male. He presented with 2 months of giddiness, frequent falls, and decreased food intake of 1 week duration. Admitted to 1 episode of seizure. Patient was there. As per the guideline therapy, we are given 3% saline, normal saline. With this dehydration was corrected. We were given antibody for the fever suspected infections. And the CRP was elevated, so we gave antibiotic. Last 3 days, we were giving 3% saline, IV fluid, normal saline, and all other, we addressed all the symptoms as well, but not improved at all. Patient asking, sir, attendant asking, why serum sodium is not improving in spite of your treatment? Solution is, again, we revised the history. We took the history that patient was taking tablet carbamazepine last 40 years. He has developed a seizure 40 years ago. He was prescribed a tablet carbamazepine and he was continued to take medicine without any further consultation. And once the history was taken, stopped carbamazepine, the next day the sodium came to a normal. So it is nothing but a SOIAT. The carbamazepine increases the secretion of ADH and increases the sensitivity of ADH in the renal tubules, thereby increase absorption of water, thereby persistent hyponatremia in spite of your treatment. What is the lesson learned? Drug history, that's the one who will help for the diagnosis as well as the treatment. We have the third case history, is a 45-year-old male, is Mr. D. He came with a swelling ulcer, grade 2 ulcer with a high-grade fever, cellulitis, and then urea creatinine was elevated, high-grade fever, CRP was elevated, total count elevated. Very simple. And blood sugar on admission was 506. So when sodium on admission, it was 120, so 138. So what you have done? So this is nothing but the hyperglycemia causing hyponatremia. That's called transdilutional hyponatremia. We have not corrected anything. Just we have given normal saline, corrected this blood sugar. With the normal saline, sugar came down. The next day itself, sugar came to 134 and become all right. So what is the lesson learned? Is hyperglycemia per se can cause hyponatremia if blood sugar is higher, and that's called transdilutional hyponatremia. The correction is only normal saline, nothing else. So how hyponatremia diabetes? Diabetes is a hyper-concentrated solution. It absorbs the water from the cell. If we have a diabetes, increased water absorbed from the cell called cellular dehydration. Not only the body dehydration, it's a cellular dehydration. Not only that, polyuria, this increased excretion of urine. If up to 400 milligram %, if more than 100 milligram % increase it decreases the serum sodium by 1.6 milliequivalent per 100 gram, but if more than 100 milligram percent blood sugar, it increases the sugar, decreases the sodium by 4 milliequivalents per liter. So what is the lesson learned? It is uncontrolled blood sugar caused hyponatremia. Treatment was only the normal saline. The fourth case, it is a 60-year-old Mr. E.B. lady, a person with 3 months of fever, chillness, and body pain, tiredness, and history of urinary symptoms. We have suspected probably some infections in a diabetic lady. So we treated, controlled the infection, blood sugar was controlled, as well as the sodium was corrected. With the hemoglobin also very low, it was 7.8. And so total count was 18.9. And subsequently developed hypotension, possibly sepsis-induced hypotension, because the total elevated, the CRP elevated, fever was there 3 months, dysuria, probably UTI. You have taken a CT scan, it was showing emphysematic pyelonephritis. So what happened subsequently, and what is the cause of fever? The cause of fever is emphysematic pyelonephritis. Patient was treated with a high dose of meropenem, 1 gram 8 hourly, and patient improved transiently and subsequent again started having fever. So in spite of 5 to 7 days of meropenem, adequate dose which is sensitive to the bug E. coli, and it is not getting corrected. So what does continue to have fever after a short period of improvement? Then what is suspected fungal sepsis? So subsequently we have started on this anti-fluconazole, that is fluconazole antifungal therapy. The patient became all right. So and subsequently during meantime she has developed anasarca, hypoalbuminemia, anemia, all these things, and you are all corrected with this albumin correction, hemoglobin correction. It is nothing but a capillary syndrome secondary to the sepsis, and the treatment of hypoproteinemia is only correction of sepsis. So that is what is the lesson learned? The lesson learned is hyponatremia and hypoproteinemia. Hypoproteinemia due to capillary syndrome. If you correct the sepsis, hypoproteinemia improves. So that is a lesson. And also we had the fifth case we had, the 47-year-old male female who present with abdominal pain of 20 days, vomiting, a 1 week duration, history of fever, decreased appetite. And subsequent hemodynamically stable, patient was treated, and she was treated for hemicolectomy 2 years ago, and this patient improved after the corrections, and patient was all right. Because she had abdominal pain, we had a CT scan and abdomen, and because she was CA colon, we was treated 2 years ago when we suspected secondaries. There is no secondaries in a MRI abdomen, and the CT scan also done, and we finally showed as only mild adhesion. So patient was corrected, treated, sent to home, and patient became all right. And subsequently 4 days later, she got readmitted with the similar symptoms, vomiting, tiredness, abdominal pain. The sodium was again 128, and now the problem is, what is the solution for this? The problem is that the abdominal pain and vomiting is due to adhesion, and the ones adhesion surgery done, adhesiolysis, the patient completely improved. What is the lesson learned? Treat the cause. Adhesion is this, remove the adhesion. Only then the sodium will come down. Don't keep pumping the sodium. Case, it is 6. It is a 38-year-old male presenting with yawning, tiredness, fever of 3 days, dysuria, hiccup, all these things. And there was an hyponatremia. This 13-year-old male present with yawning, nausea, vomiting, giddiness, tiredness. So the sodium was, it is 116. It is very difficult. See, how young man with the normal features, how can he have? But he was hypertensive, was taking medication irregularly on and off. And patient was treated and found to have taking the chlorthalidone. The chlorthalidone was the cause of the hyponatremia. Stopped the chlorthalidone, patient improved, the hyponatremia improved. So only after taking. What is the lesson learned? The history of the drug history is very important when you especially treating with hyponatremia. Here the case of hyponatremia was due to chlorthalidone. Case number 7, it is a 66-year-old female who is known asthmatic 10 years, and she was taking medication for asthma on and off, present with abdominal pain, vomiting, tiredness, loose stools, and the BP was low at the time, and she was taking dexamethasone, Deriflin on and off whenever she gets the symptoms, every weekly or once in 2 weeks like that, and present with the things we suspected that you get adrenocortical insufficiency, and that we have done a serum cortisol level, it was low, so hence it was started with the dexamethasone, and to correct it, and patient is improved, and followed by the that is a prednisolone, the melanocorticoid activity has got, it is good to improve, patient clinically improved. So she was having subsequently the low subclinical hypothyroidism. So subclinical hypothyroidism treated with the thyroxine. Adenocarditis insufficiency was treated with this dexamethasone and prednisolone, followed by prednisolone, and patient clinically improved, patient was discharged. Again readmitted after 3 months. After that, for the second review, patient was tapered, the steroid dose was tapered after 2 months, and third month, fourth month, it was completely stopped. After 3 months of stopping the therapy, she readmitted with hyponatremia. Then subsequently learned that that dexamethasone can cause adenocarditis insufficiency lasting for 1 to 2 years. So if your patient is on chronic dexamethasone therapy, the steroid therapy should be given for at least 1 to 2 years, because it will have adenocarditis insufficiency up to 1 to 2 years, not with the short-acting drug. It is only a long-acting drug. There is a lesson learned is that the dexamethasone is a cause for the problem, and last 10 years, no hypokalemia at all. She says, oh, you give me the sodium medicine, sir, sodium salt medicine, sir. That is called prednisolone. So she used to get 5 milligram alternate days. So there is no, she never had last 10 years. So that's a solution. Hyponatremia. Last case, it is the 46-year-old male who is present with acute abdominal pain, vomiting, and found to have is a chronic alcoholic, found to have acute chronic liver disease. Subsequently, and the patient was the sodium was very low at the time of admission, and potassium also low. So potassium was 2.5, sodium was 125. So the problem here is, unless you correct hypokalemia, hyponatremia will not be corrected. Because for hypokalemia, potassium will come from the intracellular to the extracellular, and so potassium comes, sodium goes inside, for extracellular to intracellular. So what happens? Already hyponatremia, further hyponatremia. So if you want to correct hyponatremia in a patient with hypokalemia, you have to give hypokalemia and then correct the sodium. That is the solution for this. So we have done that, patient become all right. So these are the lessons learned. So what we have learned was that, had we picked up these problems early, could have prevented so much of challenging problems by us. So the gaps existing in knowledge is that delayed recognition due to non-specific symptoms, over-reliance on the laboratories rather than the bedside clinical examination, and lack of standardized clinical tests for early diagnosis. So that is in mind. So we have done a study in our hospital, it's around 100 patients, to identify the hyponatremia early so that we can prevent the complications. Methodology, as usual, get admitted with any symptoms with low sodium sugar was admitted in hospital. The 100 patients, out of 100 patients, 51 were male and 49 were female, almost equal distribution. Age was common, age was 40 to 60 years. It is 39% when compared to 8 years. See, all other studies showed that more than 65 years more common, but in our study it was only 40 to 60 years. And the comorbids are commonly seen comorbid in our study was 59 patients out of 100. That is hypertension, 21 patients, and comorbids, other things are 7, 3, so like that. And of course, the presenting complaint, what we have seen was this, the most important thing is presenting symptom. What are presenting symptom? The most of the 72% of the patient among 100 patients present with the history of decreased food intake. Almost 72 patients of 100. So, and followed by nausea, headache, vomiting, and 16% had giddiness. So if you had giddiness, nausea, vomiting, and the decreased food intake, comes around 88 patients out of 100. So 88% of patients had these symptoms before admitted to the hospital. So if you identify this, you could have prevented that. That's the thing. The postural hypertension is not very much, and only 16 patients had, and blood pressure not very much variation blood pressure. Pulse rate no variation, and respiratory rate was slightly increased. So more the respiratory rate, severe the disease. That is what observed. It was increased respiratory rate was in 43 patients. Other patients it was normal. SpO2 no changes. So almost all patients had 100 SpO2. CBG was around the 90 to 200. In all patients, most of the patients, around 74% of patients had blood sugar of only 90 to 200. It is not the high blood sugar causing dilutional hyponatremia. It is not the high blood sugar causing the problem of all other things. It is only a solution of the syndrome of inappropriate ADH secretion. So the serum level on admission, it was minimal. The mild hyponatremia was only 52%, and moderate is 41 out of 100 patients. So 41, only those who had moderate to severe only had severe symptoms, and less than 125, only 7, and of the 7 patients, all are organic problem. So if sodium is less than 125, what we observe is everything, they are having some organic problem, not the metabolic of other conditions. There's a different organic problem, so that has to be ruled out, mostly malignancies and other things. And of course, drug-induced hypernatremia, we have seen only the 11 patients out of 100. The results analysis, we have analyzed the results when compared to the other national literature, that the sex, no prediction. Yes, it was observed in other studies. And the second thing is the maximum amount numbers observed in 40 to 60 years. But other studies, like done at Kerala, Canada, Turkey, and Sweden, all these things they have studied, only 30 to 40%, all observed beyond 65 years. We have observed 40 to 60 years. So lesser years, even lesser age group, this hyponatremia is very common in our study. And the mean age was only 40 to 60 years. So the symptom analysis, none of the references included decreased food intake. Everyone included nausea, tiredness, headache, vomiting, giddiness, postural hypertension, but none of the studies has included the decreased food intake. But this is the commonest symptom described in our patients. So this is a unique one. So that's what is something that, and then I put it into chat GPT, why this is so. You are great, the observation is great. So far no literature is mentioned like this. Continue to do a study, I help you in publishing the channel. That was by the interpretation by the chat GPT. And the decreased food intake was there. And of course, early diagnosis, the idea is that if you do 88% out of 100, you could have picked up even before admission coming at that. Before admission, all these patients had these symptoms. And this was the association. Of course, then we are referred. Why there is decreased food intake? Is it a decreased food intake due to hyponatremia or something else? This clearly shown in the literature, the decreased food intake is due to hyponatremia, cerebral dysfunction. The earliest symptom of cerebral dysfunction by hyponatremia is decreased food intake. There is a literature. So it is not a publication by any studies. So that was very useful. And of course, the vitals were not any much related. And diabetes was very much related. Why diabetes? All other studies in India and across the globe also, they said only 30 to 40%, 30 up to maximum 14%. But in our study, it was only 59%. 59% had diabetes. The question is that diabetes is more here. We are living in a place more diabetes, so more incidence. That is what the interpretation by the authorities. And of course, and why this occurring in even though diabetes is there, no high blood sugar, no uncontrolled blood sugar, only 100 to 200 only the blood sugar. That indicates it is not due to sugar per se, it is due to decreased food intake, due to nausea, or this is due to syndrome of inappropriate secretion by increased ADH secretion, or by your the drugs induced. So that was explanation that is we observed in our patients. And serum hyponatremia severity. So severe hyponatremia, severe the disease. And less than 125, definitely they are having some organic problem. We need to be evaluated to identify the cause of the disease. And of course, hyponatremia is common during summer. Then why this? This so far we are practicing only during summer. Is very obvious is that Chennai is a very highly humid area. It's a high temperature with a humid area, so increased sweating. Sweating is actually, even though hypotonic solution, the sodium is last in the sweating. And when you take only water for the drinking, so you further dilution hyponatremia. So the excess water intake without salt, in the event of increased sweating, where the sodium is lost, with hypotension, you precipitate hyponatremia, and that is a positive. That's why they are coming to the hyponatremia to the hospital. So that was the summer, and they are working outdoor. Most of the people are low income group, middle income group, they work in outdoor. So they get exposed to the sun exposure, and decreased food intake, and decreased water intake, and decreased salt added fluid. They're taking only plain water, probably all these things. And in the elderly, the thirst mechanism is decreased. They don't take water, and they already decreased water inside the body, that they can contribute for this hyponatremia as well. And the medications commonly used, most of them are hypertensive. They're taking hydrochlorothiazide or hydrochlorothiazides with these drugs, these modified anti-epileptic drugs, like carbamazepine is a very common drug, and alcohol will inhibit the ADH secretion, increase the diuresis that is can cause. So these are the explanation given why in summer it is high. And the solution is prevention of hyponatremia in summer. So we identified challenges, we have managed the cases of challenging problems, we have analyzed our local problems. Now solution for the problem. The solution is very simple. Give ORS. ORS for all people who are dehydrated, you give ORS solution, the electrolyte-rich fluid instead of plain water. It's a plain water, you give electrolyte fluid or salt-added fluid. And salted buttermilk, lemon juice, or tender coconut with salt, pinch of salt. This is a new concept I was listening or hearing. Tender coconut with a pinch of salt. Tender coconut is a plain water with potassium. If your patient already having a lower threshold of hyponatremia without symptoms, if you give 2 tender coconut, it dilution hyponatremia precipitate because already is at the level of threshold level, suddenly precipitates. So when you give tender coconut with salt, you can prevent hyponatremia. I'm not talking about the sodium, there is potassium. Potassium rich, this is tender coconut, but sodium is low. So that is the one thing you should avoid. Then avoid exclusive plain water without adding salt. In summer, we are thirst, we are taking water, especially elderly or more comorbids and those who are having drugs and sickness. Please avoid plain water only, but you can take plain water as a normal levels of maybe 1 to 2 liters, 1 to 1.5 liters, but not excess. That can precipitate hyponatremia, and monitor the elder individuals for the warning signs. So what's the lesson learned from our study? Those symptoms of hyponatremia are non-specific. The commonest symptom observed in our study was a decreased food intake, nausea and tiredness. So any patient comes with a history of, especially elderly or with the comorbids, if they come with this symptom, please look into the sodium, think of sodium. If you are not able to do sodium, at least give sodium containing solution, it will solve the issues. And you need a high index of suspicion. It can make the diagnosis of hyponatremia early stage, as early as 88% of the cases you can be correct if they comes with this decreased food intake, tiredness, fatigability, nausea, vomiting in the elderly. And the clinical examination and laboratory will help you in assessing the severity of the disease, but the history will give the diagnosis of the disease. If you are diagnosed, you are treated. You miss the diagnosis, you cannot treat. So that's a lesson learned from the study. So the take-home message, friends, do not forget buttermilk with a pinch of salt. In elderly individuals, with dehydration, with history of decreased food intake and fatigability in summer, it's like giving sugar solution for hypoglycemic patients. When a patient is hypoglycemic, you give sugar solution, become all right. Similarly, you give buttermilk with salt or salted solution in a patient with hyponatremia, become all right. Of course, you need to evaluate. So, I like to quote the proverb by Benjamin Franklin that the ounce of prevention is worth a pound of cure. It's very well applicable to this hyponatremia. Thank you very much for your patient listening.
Thank you, Dr. Parandaman, for a wonderful case illustrations as well as the studies. As this is an oration, there will not be no questions. Thank you, Parandaman. Yeah, thank you very much. Give a big round of applause for him. Thank you. Next oration, sir. Can we call or are you going to call? Next oration.
On Professor M.S. Amaration oration is going to be orated by none other than our senior physician from Erode, Dr. A.S. Sendil Velu. This is on metabolic dysfunction associated with fatty liver disease. The great masquerader, Dr. Sendil Velu, sir. This time also, I invite Dr. Gunasegar to read the citation and do the formalities.
நீங்கள் எடுத்துங்க. Center. Good evening. Association of Physicians of India, Tamil Nadu State Chapter, Dr. M.S. Amaresan Uresan. Dr. M.S. Amaresan Uresan is instituted in honor of Dr. M.S. Amaresan, who is the father of nephrology in Tamil Nadu. He is the first nephrologist from Tamil Nadu Medical Service and founded the Department of Nephrology in Madras Medical College in the year 1971. He also founded the Indian Society of Nephrology as well as Association of Physicians of India, Tamil Nadu State Chapter. The Association of Physicians of India, Tamil Nadu State Chapter, with great pleasure is pleased to honor the prestigious Dr. M.S. Amaresan Uresan for the year 2025 to Dr. A.S. Sendilvelu, MBBS, MD, FICP. Dr. A.S. Sendilvelu studied MBBS from Kilpak Medical College in the year 1990, Madras University, and MD from Madras Medical College in 1998, Madras University. He underwent training in diabetes and critical care in the year 1999. He is the founder of Erode Diabetes Foundation in 2001. He is the medical superintendent, senior consultant physician, and diabetologist at Maruti Medical Center Hospital, Erode. Dr. A.S. Sendilvelu is the executive member of Association of Physicians of India, Tamil Nadu State Chapter since 2018, life member of Indian Medical Association, National API, and currently our Vice Chairman of Association of Physicians of India, Tamil Nadu State Chapter. Dr. A. Sendilvelu is an invited speaker in Tamil Nadu API Conference, State Tapicon Annual Conference since 2019, invited speaker in National API Conference, APICon 2022, 2023, 24, and 25. Invited speaker in RSSDI, State Chapter Track. He is the regional faculty for certificate course in evidence-based diabetes management, training for doctors in association with Public Health Foundation of India and Dr. Mohan Academy, still 2010 till now. He is a regional faculty for advanced cardiac and diabetes management course by the Public Health Foundation of India since 2024. Dr. A. Sendilvelu is the Fellow of Indian College of Physicians awarded in 2025. He has contributed a chapter in the API textbook of medicine 2023 and 2024. He has written a book on diabetes in Tamil, that is Living Happy with Diabetes and its complications and diet and lifestyle modification, and participated in many post-marketing surveillance trials conducted by Aventis Pharma since 2002, Novo Nordisk since 1999, and he is the principal investigator in landmark trials in 2018 to 20. The Association of Physicians of India, Tamil Nadu State Chapter takes immense pleasure and honor to award the prestigious Dr. M.S. Amaresan Uresan to Dr. A. Sendilvelu at the 21st Annual Conference of Association of Physicians of India, Tamil Nadu Chapter, Tapicon 2025 at CMC Vellore.
Respected chairpersons, respected all TNAPI Secretary, President and all the office bearers, and the Tapicon 25 Organizing Committee Chairman Dr. Vetrivel and the team, and Tamil Nadu API and API Vice President Dr. Palaniappan and all the team members who has bestowed this opportunity, and I'm humbled to receive this award and give the oration based on MS Amaresh Award, because he was our professor when we were all doing an undergraduate in Rayapata Hospital in 1984 to 89. And the topic given is a metabolic dysfunction associated steatotic liver disease, which is a great masquerader, because we will let you know in another 20 minutes why we call it as a great masquerader. As an individual disease per se, the fatty liver is being known, and we have been observing for the past, say, 45 years, from the day the ultrasonic imaging became a tool to image liver in routine abdominal screening and various pathology. So as the days went, we always associated fatty liver being a finding incidental in our imaging technique. And for many years, we did not attach any importance as a disease modifying or precipitating event. So time and again, after so many years, we observed, and with various studies came that it is not only a liver disease which has a multiple implication based on the metabolic parameters we all see. Then the term NAFLD is changed for the past few years because it has an attachment, and the risk factors association make the precipitating disease sooner or later depends upon the accumulation and the progression of the fatty liver. So be it elevated triglycerides, low HDL, or type 2 diabetes or pre-diabetes in obese person, obesity per self, as well as the high blood pressure which is coexisting in majority of type 2 diabetes, we all see. So these 5-6 conglomerate of associated factors along with NAFLD makes it a very, very important organ which we have to take care very well, like pre-diabetes prevention and lifestyle modification to prevent the progression of NAFLD. So then the term now we coin as metabolic associated steatotic liver disease, where as a basic classification we do to stratify the decision making in tackling each and individual metabolic fatty liver disease. So for this, as any patients who have more than 5% accumulation in the fatty liver on imaging, we put it as fatty liver. Along with that, if any other risk factor like obesity, hypertension, pre-diabetes, diabetes, or elevated triglycerides, we stratify accordingly. So if there is any associated feature pertaining to metabolic syndrome, we put it as metabolic liver disease, or it is only a fatty liver with other risk factors, not which obvious, we put it as MASLD. So when there is no other risk factor apart from fatty liver, we put it as cryptogenic fatty liver disease, or steatoliver disease, or any other disease like monogenic disease that precipitates the fatty liver. So these are all the important classification we work up based on so many years we have seen the fatty liver incidence. So this makes us a better approach to control fatty liver right from beginning. Because many patients, when we say right from PG days, I used to bring patients for imaging in the ward. Later, when I went training in Apollo Hospital for two months about imaging, ultrasound, color Doppler echo, only after 10 years that we were recognizing in around 98, 99, in the corporate hospitals with the setting up of physician, master checkup physician and gastroenterologist, they give more importance to making the fatty liver is not only incidental finding, that it is an important early factor which we take care well, so that the future occurrence of either diabetes or dyslipidemia or metabolic syndrome can be reduced. So they discuss, they take a lot of time to evaluate based on the history with the LFT and then platelet count and then also their habits, and they give more emphasis on reducing the lifestyle modification advice. So these are all very important, because now time and again after 30 years we see the global prevalence around 25%, whereas in India it is 38.6%. And what is worrying is the 60% approximate associated in any metabolic disease, be it obesity, diabetes, hypertension, dyslipidemia. Along with that, what is more concern is around 35.4% of children between age group of 18 to 14 are having lot of obesity, and when you screen, they have lot of fatty liver. So that's why I started putting this in our social media, including YouTube Shorts and Reels, and most of the opportunity in the school. I used to conduct classes in schools around Erode right from 2009, stating that obesity and lack of physical activity in children should be motivated. So that the almost 1/3 of children, especially after this COVID, when all the work, all the housework and teaching made with cell phone and smartphone and online classes made them to sit for a longer time, and along with that they take a lot of junk foods which make them more central and more preponderance of early IGT and pre-diabetes and diabetes sooner. So these things we have to take opportunity to discuss with our patients, especially when we are free in a lean season, so that we can captivate more patients, we can screen more patients, we use this opportunity to bring more lifestyle modification among our patients. So these associated conditions like obesity, which is almost 90% along with fatty liver, and type 2 diabetes almost 70%, hypertension almost 68%, and high triglycerides 83%. So whenever you see a dyslipidemia of triglycerides more than T50, 250, and then obesity along with pre-diabetes, then do an ultrasound imaging at least to say the fatty liver and associate all these factors to treat effectively for a quite long time. And this is more important that many of the patients as well as many of the physicians are not really keen in taking fatty liver a serious indicator of future disease. So that's why in various Asian studies survey done with 1,000 Asian residents in 2023 revealed almost 72.8% of people have heard about NAFLD, but they don't know what is it actually. They think that it is only a fatty deposit in the liver. What is that? There is no symptoms. Obviously, among the patients who have fatty liver makes it a very, very difficult one to treat and maintain follow-up regularly. So the awareness about MASLD as well as with the patients as well as with the physicians are very important, because even among the primary care physicians, healthcare providers, even majority of senior physicians, the survey done showed that 70% of patients had very low KAP score, knowledge about the illness, and 50% of HCPs just know that there is fatty liver, but should we treat, how to treat, when to treat, how long we have to treat, are all the questions they have in mind. They don't sincerely follow and advocate to many of the patients who they say with MASLD. So this has to be removed. That is why we want to sensitize. That is why Dr. Vetrivel sir again asked me to talk about this topic in this Tapicon conference. So the fundamental reason most of the studies focus is on the occurrence of insulin resistance, which makes more triglycerides accumulation in the plasma as well as the liver. Ultimately, it becomes fatty liver. So insulin resistance, which can be reduced whenever we focus on obesity reduction, at least 7% to 10% reduction in the weight, as well as regular physical activity, right from children up to adults who are not diabetic, who have only obese, metabolic syndrome, pre-diabetes, or children with obesity. So the higher prevalence is not only about the fatty acid deposition, but also the fibrosis content. Compared to other people in India, when we do a lot of fibroscan analysis, that is the vibration mediated transluminal assessment of fibrosis as well as the fatty composition in the liver with the fibroscan, which showed that almost 30% of fatty liver patients have at least grade 1 fibrosis, which is a really worrying one, because the fibrosis which is present will rapidly progress into stage 2, stage 3 cirrhosis and constricted liver, and later for long run, if we don't recognize and treat cirrhosis, led to HCC later. Carcinoma may occur, we don't know the exact incidence in our part. So better, along with fatty liver, we should quantify the fibrosis content of each patient, then we can treat accordingly. For this, the International Journal of Endocrinology Medicine published in 2024 showed higher BMI patients, those with AST, ALT elevated, along with that platelet count will help us to assess the risk factor involved in assessing the severity and the progression of MASLD. Basically, we all know that the NAFLD, MASLD combination of all these intrinsic factors starting from insulin resistance, hyperglycemia, oxidative stress, and systemic vascular inflammation, endothelial dysfunction, genetic phenotype that marks most of us prevalent to fatty liver disease, as well as atherosclerotic dyslipidemia in our part. So all these may lead to any one of the future non-communicable disease, be it stroke or peripheral artery disease or coronary artery disease or chronic kidney disease. So all these can be reduced or can be prevented if we identify MASLD early and treat. So the clinical relevance, we all know that why we treat this. About 20% of NAFLD go to steatohepatitis. Then in another few years it may go to cirrhosis, another 15%, and HCC may occur on another 15%. So ultimately they do live because all the MASLD and many are alcoholics also along with this NAFLD. The progression of mild NAFLD, mild fibrosis to severe steatosis and cirrhosis are very rampant. The duration we cannot predict that it may take longer time. So especially when they have diabetes, it's much higher. So that's why the EACD and other national, international federation again emphasizes that the management of metabolic dysfunction associated steatotic liver disease, because any one of the metabolic abnormality will be there in all the MASLD patients. It may be obesity, metabolic syndrome, pre-diabetes, diabetes as well as hypertension or elevated triglyceride. So new guidelines emphasize again early screening of MASLD, especially in patients with type 2 diabetes, obesity, and it is a mandatory that all healthcare professionals should remember to screen for fatty liver. So a basic ultrasound imaging will be very helpful. Along with that, the assessment of AST, ALT and platelet count will help us to do a 5 score 4. So these two are very important to stratify and start treatment earlier. In most of the patients we see every day. So this FIB score is very important. All the smartphone you have, you can type in the Google FIB4, you will get the all the software with the boxes. You enter the age, you enter the AST value and ALT value. Remember AST, ALT, sometimes we forget the SCOT, SGPT. So in the bracket, you note down and enter properly, don't reverse it. And then platelet count, the score will be automatically come like EGFR. So once you calculate the score, if it is less than 1.3, they have a very low risk of NAFLD and fibrosis. When the score exceeds 2.67, they have a high risk of developing fibrosis, cirrhosis sooner. And the in between 1.3 and 2.67 is intermediate. So all the three are very important. Even though if it is less than 1.3, when the fatty liver is high, obesity is more, type 2 diabetic, then we have to treat those diseases associated with the MASLD very well so that we can prevent it in long run. Because this is what I've been doing for the past 20-25 years from the day we were trained in Apollo after PG, and I came to Erode in 1999. From then on, we keep on doing first for our relatives, then friends, now with all our patients. Because from 2001, we had a lot of master checkup programs. So we picked up a lot of patients who have been recruited initially with exercise, lifestyle, vitamin E and UDCA. And now for the past few years, we have excellent drug to add on and give better treatment. So these are very important so that this treatable cause, and more important, we have a good number of regular patients along with type 2 diabetes, hypertension and CAD. So these patients, only thing is we have to talk properly, we have to communicate, emphasize the importance of this hidden disease in their liver. FibroScan, you may be also knowing, many companies now have come with a free FibroScan assessment in almost all part of the town, entire India, especially when you have Sun Pharma, you have Abbott, you have Zydus, all the three companies come unless you ask. Now you can ask these companies to bring FibroScan to once a day, it is free. Otherwise in Chennai they cost 2,500 and the gastroenterology center they charge 1,500, which we are doing freely at least once in a month. We do screen 100, 150 patients once or twice a month. With that, we calculate the liver stiffness and controlled attenuation parameter CAP for assessing the liver fat content and liver stiffness with kilopascals, the non-invasive quantification of liver fibrosis. When the fatty liver is more than 2, liver fibrosis at least 1, it is very severe. We have to look at the triglycerides, we have to look at the weight, and all the lifestyle modification we advocate very well so that the reversal is much, much better. The response to treatment, we have to tell them. And the time நம்ம ஜோசிகார் மாதிரி சொல்லிடணும். Now you have dullness, now you have postprandial fullness, you have vague pain. You start treatment, within 6 weeks you will have much better. Then if you give drug, even weight loss 10%, even diet control with reduced triglycerides will have much better quality of life. Along with that, when you advocate tablets and follow up, the response is much, much better. Then they will adhere to the treatment. So this is the algorithm of diagnosis. Any type 2 diabetes, obese, those who have fatty liver, we estimate FIB score with the automated formula in the smartphone, assess with less than 1.3, more than 2.67, or between the two. So if all the three we have to regularly follow up, assess once in 3 years. So we do a fibroscan at least 6 months once. We do ultrasound imaging once in a year, and do triglycerides estimation along with part of the lipid profile every 6 months. So based on these things, we can continue treatment, provide effective weight reduction program, nutritional support, exercise program. All these helps them to reduce the fat content, to reduce the progression of fibrosis in long run. So as such, the management approach is very simple. What we do for diabetes, hypertension, obesity, the same thing we apply for this fatty liver. Only thing is we continue to emphasize that it is not only for diabetes, it will take care of the fatty liver reduction also. So for that, we again reinforce, look at the fibrosis content, look at the fiber content they take, you calculate the fiber intake, at least it should be above 25 gram, and protein content, and reduce the high transgenic fat or trans fat. So along with that, managing obesity and type 2 diabetes always take the center stage. We have to emphasize on reducing A1C less than 7. Along with that, at least 10% reduction is possible. Now we do get all GLP receptor analogs with GIP and GLP now available for the past few months. It is better we start giving more drugs to reduce fat first, obesity first. Automatically the MSLD will come down. So these are all the pharmacotherapy. At last only the bariatric surgery we aim. So the lifestyle modification is the cornerstone in approach of all these metabolic disorders. So healthy lifestyle helps to beat type 2 diabetes. Same thing for reduction in the progression of fatty liver. Be it regular at least 30 minutes of exercise cycle, a healthy diet which comprises of high fiber, a good protein of 1 gram per day, carbohydrate around 50%, and fat around 10 to 15%. So all these makes a balanced diet with 5 servings of vegetables and fruits, protein at least say around 20%. All these will emphasize them, and now with the chat GPT, we devise all these cooking and then recipes with various types and menu every week. So it's all now made simple. Only thing is we should take some time. We train our dietitian, counselors to devise, depends on our patient's mindset and taste acquaintance. So all these things are possible. We have to do and give some more time to plan and devise and execute this. So now all the diet is very simple. So we can plan and tell them, they follow. What are all the alternates? What are all the diet we can plan, a weekly menu. If you put in GPT, it gives. You give a calculated diet for 60 grams protein, 25 grams fiber, a non-vegetarian diet or vegetarian diet or mixed diet. It gives a beautiful diet plan for 3 main meal, 2 snacks every day. So you can try and then adopt to our patients. Apart from this, the drugs we now follow for the past 10 years, which instantly has great impact on the fatty liver reduction, is number 1 SGLT blocker. So right from 2013, we are using a lot of SGLT blockers, which along with good diabetes control, we have seen a lot of reduction in the fatty liver and good quality of life. So it reduces body weight by considerable 3 to 4 kg, along with the uric acid level. And also, these reduces the ballooning of hepatocytes, fibrosis reduction, and inflammation of steatitis is reduced in long run, more than 2 years. So this is again endorsed by this ELIF trial with empagliflozin and effective study with dapagliflozin and omega-3, 6 acids, and carboxy acids. So all these made the usage of canagliflozin, dapagliflozin, empagliflozin in treating diabetes and also to have effective influence on the fatty liver modification. So that is a very important aspect that indirectly it helps to control fatty liver very well. And then now, as I already told, the glucagon-like peptide, which is a quite important tool in not only reducing weight, not only controlling diabetes, also it has a very good impact on the reduction in the progression of MASH. So all these GLP-1 receptor analogs, starting from exenatide up to semaglutide, is now there. Now only we have got Mounjaro, that is GIP and GLP-1. So before that, all these has a very good impact on the fatty liver composition change. So almost all have almost about 20% up to 58%, especially semaglutide once a day 0.4 milligram has a very good impact, and also other liraglutide or weekly dulaglutide. And these are all the other changes with the GLP-1, GIP, GLP, and combination therapy of tirzepatide and other newer agents, how it impacts. Almost if you see, efinopegdutide is 73%, tirzepatide 44%, and these are all the newer, all other agents are almost 76%. So now what I have been using, and the recent approval came some few years back, almost from 2018, 19, 20, 21 is Saroglitazar, which is the Indian innovative product, a dual regulator. That is the usage. Initially, we thought of only reducing triglycerides, especially when it is above 500. We used for dyslipidemia and diabetes especially. So later, with association, all the studies came that it is quite useful also to reduce fatty liver. So from 2021, we have seen a lot of good results. So this dual PPR agonist mechanism of action, you all know that it influences with its stimulation effect, reducing insulin resistance and mobilizing the triglycerides, which is due to abnormal insulin resistance, very well from the liver. So the evidences for this from the recent USA study also came with 104 study, patients recruited, showed that Saroglitazar 1 mg, 2 mg, and 4 mg was demonstrated over a period of 16 weeks. And the objective of the study was change in the endpoints of FUN analysis set point from baseline to week 16. So that showed that those patients which are in gray chart were Saroglitazar patient and the blue one is placebo, which showed the effective reduction in the ALT as well as in the proportion of patients with fat reduction of more than 10%. So all these we have seen clinically for the past 4 years in our day-to-day practice. So these effective use of PPR agonist Saroglitazar was also seen in the biopsy-driven P3 study from India, which showed that all the changes in inflammation hepatocytes have been reversed. So that is a very good result and confidence we get in continuing Saroglitazar along with empagliflozin or dapagliflozin whenever it is necessary, and whenever GLP-1 receptor agonists are needed, we can use it so that we tackle both good control of diabetes and good control of triglycerides and the reversal of fatty liver. To summarize this, MASLD is an important change which connotes that it is not only an incidental finding of fatty liver, we have to attach more clinical significance in recognizing MASLD so that we look at the triglycerides level, we look at the obesity, we intensively treat obesity and also control diabetes well by adding agents quickly rather than waiting for time for the patient to take action on their own. So it's a silent epidemic we should recognize based on this, and the insulin resistance is the important underlying cause. And then metabolic disorders associated, all we know. Only thing is we attach more significance of MASLD and the metabolic disorders. And remember to always calculate FIB score index in any patient who have fatty liver with the FibroScan, which has an important vital role in selecting a particular agent for a given patient. If the FIB score is less than 1.3, you can do weight reduction, control diabetes well, and put either UDCA or vitamin E or exercise program. If it is between 1.3 to 2.67, you can straight away start Saroglitazar. If it is more than 2.67, definitely saroglitazar, regular follow-up, assessment of AST, ALT, and treating diabetes well, including GLP, will help. So these two simple tools will help us to stratify our patients and treat accordingly. So now, for the past few years, saroglitazar helps us with a less cost compared to the injectable GLP-1 receptor agonist, so that it is also approved, and so we can confidently use for many years. I have been using, it takes at least minimum 6 months to 1 year to show a very good response. So after 2 years, if they do other exercise, lifestyle modification, well, we stop and then observe for another 1 or 2 years. And I thank you very much for the opportunity.
Thank you.
Thank you.
Hello. Thank you, Sendilvel sir, for a nice talk on this NAFLD. You nicely covered everything. Just want to add that we have been, our center also been a part of that phase 3 clinical trial for the saroglitazar, which was liver biopsy driven trial. It showed almost there is a reasonable amount of fibrosis reversal also. And we are talking today about the diabetes reversal everywhere. In a patient with a metabolic syndrome with a NAFLD, 10 to 15% of body weight reduction can reverse put the diabetic patient into remission. Today that is definitely possible. Thank you very much. Just an announcement, and the Tamil Nadu chapter of the Research Society for Study of Diabetes in India annual congress is to be held on 9th and 10th of August at Hotel Lee Meridian, Coimbatore. As an organizing secretary of that and the team of all the RSSD members, I would like to welcome you all to Coimbatore on August 8 9. We have a stall here in the exhibition area, RSSD stall, where there is a registration at the discounted rate for today, tomorrow, and day after. Thank you very much.
Thank you. I request Dr. Parandaman sir to come to stage to give the momentum. I request Dr. Sukumar sir to give the momentum. Yeah.
You also please on the stage.
I request Dr. Sukumar sir to give the momentum to Dr. Parandaman sir. I request Dr. Balaburgan sir to give the momentum to Dr. Sanjay Velu sir. I also request Dr. Parandaman sir to honor the chairperson, Dr. Sukumar sir. And also Dr. Sendil sir to honor Balamurugan sir. Next session is session 4, landing mixed bag. I request Dr. Vetrivel sir and Dr. Aishwarya ma'am to take over the chair position. And the first talk is game-changing clinical trials in diabetology. I request Dr. Srinivasa Murthy from Bangalore sir for the talk.
Good evening, friends. Professor Dr. L. Srinivasa Murthy is well known to all the doctors of India. Even then, is a Vice President of National RSSDA, Governing Council Member Center API, Vice Chairman API Karnataka, Governing Council Member of KSRD, CCDSC, Indian Society of Chronomedicine, and Indian Society of Hypertension. A lengthy schedule is there, but still, I'll tell you one thing, is a human to human, and his humbleness in respecting the fellow man speaks volume. With this, I introduce Dr. Professor L. Srinivasamurthy to address us on the game changes in the
Clinical trials.
Game-changing clinical trials in diabetology. Please, sir.
This doesn't disappear. Good evening, sir. I thank profusely Vetrivel sir, Palaniyappan sir, and the entire Tapicon team for giving this opportunity. And this is like little offbeat topic. I'm sure all of you will respect this once we see some new molecules which will come up that it's not changing. It's not changing. Okay. So these are my disclosures. I'm not contracted for this talk. So I'm going to just allude upon few trials which are there and in the pipeline, and you will see the interesting molecules, how it comes up. Most of you read the original articles once the trial is out, but we conduct the clinical trials from phase 2 and phase 3. I think here Balmurugan sir is also there, who's part of many clinical trials. And this is what we do to generate the data, what you people read the adverse events. Example, the tirzepatide, what you're reading, we have done the clinical trial about 2 years back, which is out in the market today, and that is what you are studying, whatever we had reported in various centers across the globe. So one of the newer innovations were oral semaglutide. We completed the SOUL and FLOW trials last year, and you know the molecules were there now in the market. The Wegovy, which is going to be launched also, we have done the FLOW trial, and we did this last 5 years. That means pre-COVID, we have been doing that, and I've got experience with the semaglutide for about 6 years now. In the market, it is 1 year old, but I've got a 6 years experience because of the clinical trial. And in the SOUL trial, we were the global highest recruiter across 28 countries. I had recruited 49 subjects, and we retained all of them till the completion of the trial. This is about the molecule. We'll not get into that. But these are all the studies. This is how they're going to register with a CTRI number, just to show you in the CTRI.in, the website, which has to be registered. And you can see there, last modified on postgraduate thesis, is it type of trial, type of study, study design, all these will be there in the public domain. And these are all the studies which we have done. Just to show you quickly, these are some of the trials which we did. And this is a 52-week confirmatory randomized double-blind, double-dummy, active controlled multi-center, multinational. The 2-arm parallel group trial. Diabetic subjects who are inadequately controlled on metformin alone will, after approximately 2 weeks screening period, be randomized 1:1 to receive either semaglutide 1 mg, that's injectable, and canagliflozin and placebo, or cana 300 mg and semaglutide placebo once weekly. So this is what the studies will happen. And of course, this is another step trials which are basically for obesity, wherein semaglutide 2.4 mg were studied across these segments. Step 1 was the sema 2.4 once weekly in an overweight or obesity non-diabetic trial, and this is already completed now, step 1. And this is another interesting one where it is a semaglutide half-life of around 1 week, suitable for once weekly injection, compared with a bolus pre-meal insulin 3 times daily, both added to metformin, and that is what is the study done. And I'm showing you one of the other trials which are CV safety with overweight or obesity, and this is a cardiovascular outcome in people with overweight or obesity.
And this is another trial which talks about the retinopathy. All of you are aware about the GLP-1s causing worsening of retinopathy, cataract, etc. This is called FOCUS, which is going to get over this year, and next year, first quarter, we'll have the results. And this is what will going to tell us about whether these GLP-1s would cause the retinopathy or not. And this is the answer to that $1 million question as of now. And this is about the effect of SEMA on the progression of renal impairment in subjects with type 2 diabetes in CKD. And this is called the FLOW trial, and we were part of that. In fact, I was the national lead investigator for this trial from the, I was representing the country, and you can see the global expert panel list and my name there across all the countries. And this is about semaglutide CVOT trial, which is SOUL. As I said earlier, we were there. And this is still ongoing, which is called Pioneer Teens, which is a randomized double-blind placebo-controlled multinational multi-center with 52-week treatment period followed by a 12-week off-trial period. And this is for treatment of children and adolescents in type 2 diabetes. Children, adolescents 10 to 18 years in type 2 diabetes, this is still ongoing, which is again on the semaglutide part. This is another interesting trial which we are part of that. It is about 14 mg, 25 mg, 50 mg of tablet. Now what is available in the market is 14 mg semaglutide, right? So we are studying 25 mg, 50 mg of oral sema, and people are tolerating that. That is something which is interesting. And also NASH, the previous oration was on NASH. NASH trials are also going on with the semaglutide, and this is about tirzepatide. Most of you know about the molecule. We will not get into the twin creatine. But we were part of SURMOUNT-2, which were only 2 centers in the country did, AIMS New Delhi and my center at Bangalore, SURMOUNT-2. And ICODAC, we have my first Lancet publication was because of ICODAC trial onwards 10. We had that, and you know the structure of the ICODAC now, B29 replacement with the C20 icosane fatty acid. That's how they lead the name ICODAC. And of course, its exposure was distributed across once weekly dosing interval, and the glucose lowering effect is close to evenly distributed within the dosing interval, and it was well tolerated, no safety issues were identified. And this was my Lancet publication, the summary which I'm sharing you here. And these are all the various once weekly insulins. In this, we have done the BIF, you can see there, the second one, and that is the phase 2 trial we completed from Lilly. It's called Efsitora, and weekly ones we have already completed. The ICODAC is already completed. It is supposed to be launched very soon, but Efsitora is not yet launched. And this is a 78-week trial which compares the effect and safety of once weekly insulin ICODAC with a daily glargine, both in combination with a non-insulin antidiabetic in insulin naive subjects. And these are all the ICODAC trials which I am showing, onwards 4. And we were part of onwards 4, which is completed long back. Onwards 10 we are part of, which is ongoing now. And this is in type 1 diabetics. That is a 26-week randomized multicentral open label active control parallel group 2-arm treat to target, and it is going to study the effect and safety of treatment once weekly ICODAC in type 1 diabetics, which is ongoing, which has not yet come out. And this is where, just to know that FDA has put a query to the ICODAC promotion that enough data is not there for type 1. That is why it is on hold for launching. This is just extra information. Now this is another molecule which is called CagriSema. CagriSema, and we are part of this trial which is ongoing now. It is a combination of caglinitide and semaglutide. And the purpose of this another study called TRUMPH-2, which is the GZBK, which is a orforglipron, which is the oral GLP tablet of Lilly, vis-a-vis your oral tablet of semaglutide. This is orforglipron, which is for obesity, overweight. We are part of this TRUMPH-2 as well. And Zeus trial is a very interesting molecule. It's called ziltivekimab, which is a monoclonal antibody. It's a monthly once injection. It's a monthly once injection where 15 mg is looked at the risk of reduction of MACE events in people with a high risk, that is established ASCVD, CKD patients, and this they are pitching in for primary prevention in future. So it's called ziltivekimab, it's called Zeus trial, and this trial had about 80% screen failure rate because of the HSCRP levels across the globe. This was one of the worst trials to perform, and in our center we had only 10 people without any screen failure, so 100%. And this is about the SOUL trial. And it is showing 11 minutes here, 15 minutes, right? Another 4 minutes I have. The bell rang, so it's saying 11:33. And CagriSema, I'll just tell you what are those. And these are the various trials which we are part of. I'm just showing you once daily the orforglipron along with insulin glargine, which is called Achieve 4, that is still ongoing. And this was another trial, the Triplexam trial, which is about a triple antihypertensive drug. And this is what I want you to come. I'm just going to talk about 2-3 new molecules which you wouldn't have heard. This is going to be the first time you people will be hearing about this. This is called baxdrostat, which is a selective inhibitor of aldosterone synthase. This is pitched in as an antihypertensive. The mechanism you can see, it reduces the aldosterone, thus reduces sodium and water retention and reduction in the BP. It causes increased potassium retention. Unlike the mineralocorticoid receptor blockers, baxdrostat acts on a upstream at the synthesis level. Hence, it is pitched in resistant hypertension and possibly in CKD and heart failure. So it's called baxdrostat. And we are doing 2 trials. It's called BaxAsia, which is in patients with uncontrolled hypertension with 2 or more antihypertensives who are labeled as resistant hypertension. And the another trial is called BaxDuo, where interestingly this molecule is combined with the dapagliflozin. And this is studied in alone on CKD progression in participants with CKD and high blood pressure. So BaxDuo is a baxdrostat with a DAPA. You can see how interesting things are coming up. It's so intelligently matched. Of course, this is by AstraZeneca. And this is the 2 trials which we are doing. In fact, BaxDuo, I am the national lead investigator in charge for this study in India. And GZBK is another molecule. It's called TRUMP2, as I told you. It's orforglipron, which is the Lilly's weekly once tablet. And TRUMP outcomes is a triple G. Now the twincretin, which you are all launched, people are excited. Now we are studying the triple G, which is the glucagon, the GLP, and the GIP combination, which is called TRUMP outcomes. In fact, in this trial also, I am the national lead investigator, which is going to be effect of retatrutide on the incidence of MACE events and major cardiac events in participants with a BMI of about 27 with established ASCVD or CKD. This is a very interesting trial. Lot of adverse events are there with the triple G, and this is what is the triple agonist, the GIP, GLP, and the glucagon part. We'll not get into this for want of time, but it has got ileal and intestinal obstruction, lean body mass loss, so we are doing that study also on the GI adverse events. And REDEFINE 3 is, as I told you earlier, CagriSema, which is once weekly in participants with established cardiovascular disease. And this is another protocol, 7700, again CagriSema in diabetics with overweight or obesity. And semaglutide GLP-1 receptor agonist. Carglinitide is a long-acting amylin analog, that is a dual amylin and calcitonin receptor agonist, which is engineered for a weekly dosing. It activates amylin receptors in areas postrema and hypothalamus, potent satiety signals. So it would result in reduced food intake, sustained weight loss, improved glycemic control. So that is where it is pitched in. And CagriSema is a complementary dual hormone therapy where this fixed dose weekly co-formulation of carglinitide and semaglutide, synergistic activation of the GLP and amylin pathways, distinct receptor targets which minimizes the overlapping GI adverse events. So phase 3 REDEFINE, we are part of REDEFINE 3. 20% weight loss, superior A1C reduction was seen in REDEFINE 1 and 2. Now REDEFINE 3 is ongoing. And of course, potential next generation option for the treatment. And of course, CagriSema acts on the amylin receptors in the brainstem to reduce the food intake, and that's where it is pitched in for weight loss and CV safety. This is 4945, which is again talking about the new molecule, which is phase 2B dose finding study to evaluate the efficacy and safety of the Bayer's molecule above the standard of care in reducing albuminuria in patients with CKD. This is another interesting study, antihypertensive, pitched in for reduction in this. And I'm sure all of you would be hearing this term for the first time. It's called Neurandrous-EGOT. And this is from Germany, the Bayer. And this is supposed to be a soluble guanylate cyclase stimulator, SGC stimulator. It works by directly stimulating the SGC independent of the nitric oxide. enhances the cyclic GMP production even under conditions of the nitric oxide deficiency. So it eventually amplifies the endogenous nitric oxide signaling by stabilizing the NO-SCGC interaction, increases the intracellular cyclic GMP, activates the PKG, vasodilatation, anti-proliferative, anti-fibrotic. So it is potentially pitched in for targets like the PAH and the heart failure and also in CKD. So the overall result would be improved vascular tone, reduced pulmonary pressure with this. This is what we are going to have, and this is the physiology which I just was talking about. This is schematically represented. Quickly, what's in pipeline? Oral insulin's always been a failure, but this is going to be soon happening because of the semaglutide technology, the snack technology. They're going to apply this to the oral insulins as well, and the factors favoring this design action are there. For this ultra-acting, or MD is another one insulin. The Tregopil, we were part of this. This was an Indian company, Make in India. This was a TAD tablet pitching in with short-acting insulins, but it did not give the result as required. The p-values were not significant, so it did not take it further. These are all the oral insulins which are there in the pipeline apart from Tregopil. This 0801 is a promising molecule which is coming up. And of course, the basal insulin, FC-Tora, which I was talking about, Lilly's once weekly, we have completed this also. And this is another promising insulins which is going to come about, the epitope preferential insulins, which works preferentially in the liver after the subcutaneous administration, and it can mimic probably the physiology which we've been always chasing and we are not able to succeed so far to mimic the physiology of in vivo insulin. So the insulin receptor pathway preferential signaling, these are all happening. Glucose sensitive insulin, this is going to be very, very promising ones where it is going to be auto-adjust the biological activity to the fluctuating blood glucose. And glucose oxidase binding proteins or other glucose binding molecules, entities like phenylboronic acid, the PBA for glucose sensing, and that is how they are trying to do this. These are all in the preclinical studies. And to summarize, the last century has seen innovations in therapy transforming the lives of people with diabetes. In the very near future, we can expect once weekly formulations, oral formulations, smart insulins, what I showed you in the last slide, and they are glucose sensitive molecules or tissue specific that can target the underlying pathophysiology of diabetes and obesity. And we move closer and closer, not only to manage, but effectively treat these chronic diseases one fine day. Thank you very much for patient hearing. Any questions, I'll be very happy to answer.
Thank you, Professor, for the nice and vivid narration on the new molecules inculcating the diabetes and obesity and hypertension. When there are so much of molecules are coming, we will be very happy to avoid insulin when we use oral insulins. We'll have some more questions from the audience. Yes.
So somebody is awake.
Sir, I always enjoy your lectures, sir. One doubt I have from long time, sir. Semaglutide and tirzepatide will reduces the weight. But what about the bones, sir? What about the osteoporosis? In your studies and anything?
No, there is no receptor in the bone. So there are no studies available for that. That's the point.
Thank you, sir.
So a great presentation, really very nice that had oral semaglutide and a study with all these drugs. And amylin analog, the genetically engineered molecule which is implanted in the peritoneum. It releases a prevalent like substance that to keep controlling the blood sugar. So what is the scope for that in future?
So this was planned by Servier in France. It did not take off after phase 1 trial. This was a yearly once subcutaneous implantable injection, the device. So our site was selected for phase 2, but phase 1 did not give the result. So this trial, what you're talking about, is not going to take off. So it is going to be now weekly once, carglutinide, the amylin derivative, which we are doing it now, with combining with semaglutide, so that it's like a twin creatine. Basically, it acts like a twin creatine.
That's a plasmid derived the amylin analog. That is also being tried to bring down the weight reduction, bring down the weight as well as blood sugar control. What about that one? This plasmid?
I'm not aware about this. Okay. I'm not aware.
That's also for this thing.
Okay.
Very nice, but very lucid presentation. Really, I enjoyed your
Thank you.
lectures.
Thank you, sir.
A very nice presentation, sir, and I'm happy that so many trials we are doing in our part. That is very, very important. We are commendable. And what I want to know is, I have been using all new drugs right from launch, right from 1990, where Amlagod came when I just finished my MBBS. At the time it was 28 rupees. So many of my colleagues and juniors are always skeptical. நீங்கள் எது நியூ வந்தாலும் ஸ்டார்ட் பண்ணிடுறீங்க. You have to wait for 2 years. You have to wait for 5 years. We have our own mindset and hesitation. So with all the new studies we are all doing here, we have a first-hand information. So is it right to wait for few months or few years, or with the study protocol can we start immediately as and when it is launched? See, that question is always in our mind, that how long we have to wait. Because for example, Mounjaro now and semaglutide just before, and empagliflozin initially. It took long time for our colleagues to initiate because of the, what do you call it, is their
Apprehension.
apprehensions, and they are so hesitant to start.
Yeah.
Somebody will tell, how can we start? So all these things, how can we tackle in the current scenario? Because now we do a lot of research you are doing in our part. We have interaction personally. Because 10 years back it was not there. We used to get only the textbook or the print from the journal. We cannot interact. So how well we can do it now?
Yeah, so very, very relevant question in practice. Sir, I have faced 2 US FDA inspections at my center. I have faced world's first Canadian Health Authority inspection at my center. I have faced about 6 DCGA inspections at my center, all with clean chit. Now, why am I telling this? The data, initially they had inhibitions about Indian data because a lot of our people, our colleagues. And there was one person in north of India, I don't want to name the state also, where recently we had a mishap with a flight. So that state, a person had drawn sample from one individual, split it into 9 and sent it as a 9 different subject samples, and they found out blacklisted. So they had that apprehension. Now when these FDA inspectors all that come, they literally rag us for about 5 days. 2 inspectors come from USA. So the data is for sure. Now the apprehension about the new drug, for a new molecule to get approved, it takes about 10 years, it takes about $1 billion US, and the amount, like Flow, I was the national lead investigator, when they applied it for approval in the US, we were also involved as national leaders. All the country heads had to go there, meet, give us our opinion, all that. And the paperwork, if they file the papers one above the other, it is to the height of the Empire State Building. I don't know what is the height of Empire State Building in US, but that is what they told us. If we do this in paper, print out and file it one above the other, it is to the height of the Empire State Building, which is supposed to be the second highest in New York. So that is the amount of documentation which are scrutinized in the FDA. That is why everybody thrives and strives for the FDA stamp. Of course, for insurance reasons also, that is the most stringent thing. So whenever these trials have come, phase 3B, you need not have any apprehension. Phase 2, yes, I showed you the Bayer molecule, which I have never heard. I had to read my physiology and biochemistry way back in the textbooks to look at how does people think about, the glutamate cyclic GMP activator. It is so beautiful. I mean, we never thought about that. The baxdrostat aldosterone synthase inhibitor, carglutatide. We never thought about amylin. Amylin was always found out. The ghrelin and amylins were there with appetite, and none of us bothered. But today we have those, enhancers, triple G, double G, semaglutide. These are all extensively studied and multicentric. See, forget about India. What about US or Europe, where it is EMEA audits are most stringent in the world. Japanese audits, all these molecules pass through those stringent audits, inspections. That means the data is something which is always there. So the last inspection I had was for Icodec. It was an approval trial, approval inspection. Means before the FDA puts the stamp, they usually pick up randomly 5-6 countries. So India, Brazil, US, Denmark, and Spain were the 5 countries which were inspected. And after that inspection, that is like testing, randomly. So if any one of these countries find something fishy, they do not give approvals for the molecule. So approval inspections are very highest, and of course the sponsors will be very, very eager, anxious to complete that. So when we have that authenticity, I don't think we need to wait after a phase 3B trials results are announced.
Thank you, sir.
Thank you, sir.
We all know that in medicine especially, according to the ancient physician Francis Bibody, he says, anything in medicine is told. People used to say it is not important. when its importance is little established, they say it is not that much important. When its importance is established beyond doubt, they will say it is not new. So, we have to invite the older molecules. What the glutides we have been ignoring in the beginning, now it is established. Same to with the tirzepatide, which is a dual agonist. So, it is good that we should learn what is happening in the medical scenario in arena to learn new molecules. Thank you, Doctor. Please sit, sir.
Thank you. Thank you.
We invite our next speaker, Dr. Ronald Carey, to talk on the strategies to improve quality in acute care medicine.
Good evening to all. I want to thank the organizers for inviting me to speak on this topic. So the topic for today is strategies to improve acute care in medicine. I think we'll start with the Mentimeter. If you can, if you can use your phone and scan this QR code. I hope you can. And answer this questions of all patients admitted to an ICU. Patients from which area would be the sickest? First would be operating rooms. Second would be the medical wards, and third is ED. Are you able to scan it? Sorry, I'll just go back. Okay, I think for some reason the answer is not coming. Are you able to answer in your thing? Okay, I think we'll move on. So we'll see that actually this is from a study from the UK where they studied what leads to patients being admitted in the ICU. They found that of the 551 patients admitted in intensive care, 90 were from medical ward, 239 were from the operating rooms, and 222 were from the emergency department. Of all this, you can see this, the mortality. The patients from the medical ward had a very high mortality, 47.6. OR had low, 19.3. Obviously, it's a very controlled environment. ED had 31.5. So obviously, there is a high. The patients in the wards are much more sicker than in the OR and ED. So, with regards to who had hypotension, tachycardia, and tachypnea, etc., in terms of some kind of antecedent before they were shifted to ICU, those patients in the medical ward had a high number of antecedents before ICU admissions, of which 62 had antecedents during the 8 to 48 hours, which means had they been monitored, an ICU admission could have been prevented. and 53 had both within 8 and 48 hours. So acute care is an area where focus is required if we want to avoid, avoid mortality and ICU admissions. So we'll look at some strategies, I would say 4 strategies to improve acute care in medicine. First is to use, quality improvement techniques. Now we know that, the quality improvement is a major thing now. In the last 25 years, it's become a, field in itself, and it's used mainly in terms of, accreditation, NABH, etc. But a lot can be used in the field of medicine as well. How do we define quality? I had a Mentimeter, but it looks like it's not working. How do we define quality? Very often we think it's about giving the latest, latest available medicine, but we know that it's, it's much more than that. So there's the Institute of Medicine in the US, which gives understanding of quality, which is 6 domains, some core values, supported by transparency, resilience, and leadership. I'll show you the picture. If you can see this, so when we say quality, we have to think about safety, whether it's what we give is effective, whether it's efficient, accessible and timely, equity, and also eco-friendly. Now, all this should have a core of, kindness, compassion, dignity, and respect. It should be, it should be holistic, and also partnership and co-production with patients. And the whole thing is enveloped by, both on top, there is transparency, and on the low there is resilience, and the whole thing should be person-centered. So when we talk about improving quality, we have to think of all these domains. And if you want to do a quality improvement project, we need to address all domains, even though the focus could be just one domain. The most important thing when you want to improve quality is, we need data. Without data, we are just another person with an opinion. So you want to improve quality, you want to, say we want to reduce ICU admissions, we need to know, okay, how many are being admitted? We want to give the care sooner. We want to know, okay, what percentage of patients are receiving, the consultation immediately, or, or something like that. So we have to start with measurements, which is the foundation of quality improvement. A robust plan is needed. One of the very useful tools is something called a statistical process control chart, but a range of measures should be used if you want good data. This is an example of a statistical process control chart. For example, let's say, one thing we've been doing in the last month in our ward is hand hygiene rates. We did a study and found that, hand hygiene rate was not excellent, around 50% among, registrars, another percentage among the nurses, and so on. Now that's the problem. We know it's a problem. Now we need to ask the question, okay, how do we intervene? And then you intervene and then do another study, and so on and on. If we have a way in which you can collect data continuously, that'll be even more better. Once you have the data, you mark it. That's a statistical process control. Then your intervention, when you do an intervention, you can say that the outcome is changing or not. Once we have the data, once we mark it, we need to identify and define the problem. We need to write a problem statement. An example of a problem statement would be like this. Despite the importance of timely ECG interpretation for ACS patients, our AD has observed door to ECG times exceeding 15 minutes in 30% of cases, potentially delaying diagnosis and treatment. It's a problem when patients come to ED, we want an ECG immediately, but then the nurse may not be there, the doctor may not be there, and so on and on. How do we, how do we make sure that the ECG happens immediately? So you write a problem statement. Then we need to study and analyze the problem. There are so many methods. I've just listed few. One thing called 5 whys. 5 whys is basically asking the question asking the question why, you have to ask 5 times. The patient didn't have an ECG on time. We need to ask why. because the nurse was not available. Why was she not available? Because she had other work to do. Why did she have other work to do? And so on and on. 5 times you ask, you may actually get to the problem. That's one example. Fishbone diagram is another one where you draw a diagram where the end of the fish is a problem, and you can mark what are the various factors which lead to the problem. It's a very useful tool if you want to address going back to the hand hygiene thing, where we need to say, okay, hand hygiene is not happening. Why are people not using the hand rub? Why are people not washing their hands? Because hand rub is not available, because the nurses are too busy, the doctors are too busy, and so on and on. So you can actually draw a fishbone diagram. I'll show you an example of that. Another thing is called as Pareto diagram, where you list down all the causes and see what is more prevalent, what is less prevalent. Suppose, let's say, of the causes of hand hygiene, one cause is 70%, another cause is 20%, another 10%. If you address the 70% cause, you have actually sorted most of the problem. So that, in that way, that helps. So this is the fishbone diagram where you list down, for example, this is the example given here, being late for work. Why are you late for work? Process, alarm clock, breakfast, route to work, etc., equipment, and the materials, the food, etc., etc. You list down all and say, okay, how can I address this? You could put something like, increased ICU admissions, or maybe increased hospital-acquired infection, or maybe heat stroke in the ward. These are, these could be problems, and you can draw a fishbone diagram, and then you can aim to, address it. So this is the Pareto chart where you list down all the causes. If you address these two, the first two, if you address the first two, you have addressed most of the problems. 80% is done. We know that maxim where 80% of a problem is to just 20% of the of the reasons. So you just focus on that, and you have mostly addressed the problem. So based on the data that's available, we need to develop a theory and make a hypothesis for change. So you have hand hygiene, for example. You look at it and say, this is the reason why hand hygiene is not there. Let's intervene and see how the change happens. Once you do that, you write an aim statement using the SMART protocol. You can make a driver diagram where you put the aim, put the primary drivers that will lead to the change, put the secondary drivers, and you put all the change ideas on the last one. And you can focus on each of that. There's also this very nice PDSA cycle where you plan an intervention, you do it, you study the impact, and then you act again. Then you keep doing it in cycles. You might have heard of this term, PDSA cycle. If you can do a simple audit of a problem, and then you intervene, study the outcome, then act again. And this can an ongoing project in your ward or in your OPD or wherever you work. The second intervention, the strategy I would want to talk about, is clinical care pathways, where in this we try to translate the guidelines into local practice. So we know we have standards in healthcare. Standards help processes to reach a certain level of quality and ensure safety. Usually it's done by experts, measured by guidelines, external evaluation, regulation, etc. And then we have the clinical guidelines and pathways. Those are internal standards. In your hospital, for example, if you have a guideline for OP poisoning, you say, this is our guideline. And then you can convert that guideline into a clinical care pathway. So that helps staff in making decisions and also promotes best practices. It's a tool to drive evidence-based healthcare. So you could say it is a structured, multidisciplinary care plan which detail essential steps in the care of patients with a specific clinical problem. For example, you can say a clinical care pathway for OP poisoning, where the whole hospital is aware. Because a lot of departments are involved. ED is involved, medicine is involved, biochemistry is involved, and so on. And once you have a pathway, the whole, every department is aware, this is what we're going to do. In the pathway, you explicitly state the goals and key elements of care, and this also will help in communication between the various partners in the team and helps coordinate the care process. What's the purpose? Purpose is to translate guidelines into local context, specify specific steps in care with time frame, and standardize care for a clinical problem. So this is an example of an ambulatory care pulmonary embolism pathway. We know that when patients come with pulmonary embolism, it can be quite confusing for people. Whom should we call? What should we do, etc. What to do for a patient with cancer? What to do for a patient with pregnancy? So the pathway can detail all that, and if it's available for the doctors, especially in the front line, if it's available for nurses, if it's available, it'll help in improving care. You put the scoring there, you put when should a VQ scan be done, all that. The institution should make this and it should be made available. So I'll skip that. So how effective are these pathways versus usual care? In-hospital complications is less, usual care is 15%, whereas if you have a pathway, it's 9.3. In-hospital mortality is less, hospital readmission is less, and also documentation significantly improves. The third thing is an early warning score. You might have heard of the early warning scores. We all are aware of the term, vital signs, first coined by somebody called Dr. Edward Seguin, had temperature, heart rate, and respiratory rate. BP got added later. If you ask the question, how frequently are the vital signs measured? Depends on where the patient is. Often we want to stick to the TPR sheet, the temperature and pulse and respiratory rate sheet. It's got some sentimental value. You really have to fight if you want to change it into something like an early warning score sheet. But there's a growing need to identify patients at risk. We can't always expect the senior doctor to be around. So there is this concept of medical emergency team which evolved in Australia. They listed the parameters, including cardiac arrest, for which a medical emergency team could be called. They had airway, which is threatened, breathing, circulation, neurology, all that. That's how it started evolved. In the UK, from the 2002 onwards, many hospitals started using one score or the other called early warning score to identify patients at risk. It is defined as tools used by hospital care teams to recognize early signs of clinical deterioration in order to initiate early intervention and management. So soon a consensus evolved and something called National Early Warning Score came in the year 2012, and it was changed a bit and it became NEWS 2 in the year 2017. The premise of NEWS, that is the National Early Warning Score, is early detection, timeliness, and competency of the clinical response will lead to good outcomes. That's the whole point of having a National Early Warning Score. What are the components? It's a very simple score which can be used in any hospital. It doesn't require sophisticated instruments. Respiratory rate, saturation, systolic blood pressure, pulse rate, level of consciousness or new confusion, and temperature. And there's a sheet which is there in which you can mark it. A score is allocated for each parameter. The magnitude of the score reflects how extremely the parameter varies from the norm, and the score is then aggregated. And 2 points if the patient's on oxygen, and this is the sheet in which it's marked. On the left is the respiration, saturation, and then it's the SpO2 scale 2. If somebody has somebody has COPD, if they have type 2 respiratory failure, you use a different scale for for the saturation, where 88 to 92 is acceptable. Blood pressure, pulse, and consciousness and temperature. Finally, you have a total score. 4 trigger levels for clinical alert. Low score, new score is 1 to 4. You don't really have to do anything. Monitor closely. A single red score is an extreme variation in an individual Sure. Median score is 5 to 6, where patient is becoming more sicker. High score is 7 or more. So the intervention, what is required, will depend on the score. A low new score, a competent nurse should be enough to monitor the patient. A single red score of 3 means we need to, the patient needs to be seen by a clinician. If it's a medium new score, a clinician or an acute team should see. And if it's 7 or more, it should be seen by a team from the critical care. In that way, action can be done immediately. So similarly, if the score is 0, you can monitor once in 12 hours, 1 to 4, 4 to 6 hourly, 5 to 6, 1 hourly. 7 or more needs continuous monitoring. So this is an example where new score is 6, needs hourly monitoring, sepsis has to be considered. But the important thing is news has to be always used alongside clinical judgment. It cannot be used alone. And it's not for patients less than 16 years, patients who are pregnant and those with spinal cord problems. It's used across UK, used in Singapore, and other forms of scores are there in some other countries. A lot of advantages. It gives a framework for action, empowers nurses. It makes communication easier. So this, you can see, if you see this picture, as the news increases, the mortality increases. News 0, mortality is very low. With a very high news score, we have very high mortality. And the last strategy is early senior input. We know that somebody has to be seen by a senior as early as possible. Very often the sickest patients get seen by seniors a bit later. But if we have a strategy in a hospital where seniors are able to give input sooner, then it would be much better. And we have studies to show that that improves outcome. So this is the standards in UK where they say acute medical admission to be seen within a competent clinical decision maker within 4 hours and should be seen by a consultant either from the acute team or from the specialty team within 14 hours of admission to an acute medical unit. The one study, this is published by a person whom I worked with, which shows that actually overall, if there is a consultant presence in an acute medical unit for 4 hours in a day during daytime, it improves the total case fatality rate significantly. That's the last slide. Summary, acute care needs focus. We need to make intensivists jobless, which means we need to look after our acute patients well. We need to explore quality improvement techniques if we want to make changes. We need to develop clinical care pathways. Especially it's more relevant for big institutions, but the same thing can be done even smaller institutions. Use early warning scores and give early senior input. That will make an impact in the outcome. So thank you. I'm happy to take any questions.
Thank you, sir, for this elaborate discussion on how structure is important. And of course, we all are here to save lives, and if there is structure, there will be less chaos, and we can definitely save more people, and we all definitely agree upon whatever you've told. And if there are any questions? If there are no more questions, we'll go on to the next session. Thank you, sir.
Thank you.
We call upon Dr. Bala Vignesh from Vellore, and he's going to be talking about from Naruvi Hospital, and he's going to be talking on the topic of cardiac biomarkers in clinical practice for physicians.
Dr. Bala Vignesh is a consultant interventional cardiologist practicing in Naruvi Hospital. We are happy to announce that he is one of the few doctors who much attached with the Vellore district branch of API. I congratulate him, and we are welcoming you, doctor, with folded hands to deliver your lecture on cardiac biomarkers, which we have to be familiarized in diagnosis of acute events like acute coronary syndrome and other chronic events like heart failure, preserved or non-preserved.
Good evening, everyone. I thank the organizers for inviting me for this talk. So, the topic I'm going to discuss is cardiac biomarkers in clinical practice. Key points for discussion today. What are the biomarkers for MI, which we all know is the most important part of cardiology? What are the characteristics of the assay? Focus on turnaround time, the point of care services versus central laboratory measurement, biomarkers of heart failure, that is the BNP and the NT-proBNP. So biomarker, as we know, anything that's measurable to indicate either a disease state or a physiological state of the body part. And here, specifically for cardiology, it's about the biochemical marker. And as we know, biochemical markers specific for each organs are there, and my focus today will be on troponins and natriuretic peptides, focusing on the heart. And so here we see that this is the overview of the pathogenesis of acute coronary syndrome. Plaque rupture, that is just mentioning each phase and looking at what parameters or biochemical markers would indicate that particular stage. So at the time of plaque rupture, amyloid A protein, which is not measurable, may be elevated. Then intracoronary thrombosis stage, soluble fibrin may be detected, again not commercially available. Then the flow gets reduced, where perfusion imaging may help, but in the acute setting it's not possible. Then comes the myocardial ischemia phase, where immediately we may see a echocardiograph change and a ECG change. Then the state of myocardial necrosis, that is when the biomarkers troponin I or T get elevated. So the series of steps pathogenesis wise causing an MI involve plaque rupture, then thrombus with reduced blood flow leading to ischemia and infarction. If we are able to predict at the earliest, once the patient develops symptoms, the earliest any biomarker is able to help us diagnose MI, then we may prevent the final stage of myocardial necrosis. But at the moment, only at this point, the biomarkers are measured and they are of value to us. So specifically for MI, we know troponin and CKMB. I'll talk about troponin first. Troponin is the specific and sensitive biomarker of cardiac ischemia. Of course, as we know, it's a preferred biomarker for anyone suspected to have an acute MI. So this concept of suspected acute MI at any level, whether it is a rural clinic or tertiary care center, anybody with a chest pain with the symptoms suggest of an acute MI, the first step is to do a ECG and a troponin. So irrespective of the time interval. So of course troponin takes about 3 to 4 hours after the infarction to rise and generally normalizes in 10 to 14 days. But when the patient presents to us, either OPD or casualty with acute chest pain, definitely immediately do a ECG and a troponin. Patient says symptoms are only 1 hour. Is it better to wait for 4 hours and then do the troponin? No. We don't know the exact time of onset. So definitely do it at the moment he comes to you. So what is the sensitivity and specificity of this? It's about 99% sensitive. That is, negative predictive value is very good. Once troponin is negative, then we are sure that we can rule out MI if it is done at a particular time. Then rule in, it has a positive predictive value of about 70%. That is, not all troponin positives mean it's an MI. It can be due to other causes too. And we often say if the troponin is elevated, it's abnormal, and otherwise it's normal. So those terms need not be used. It should be mentioned as either it's elevated or it is not elevated. And that is better because some values of troponin based on the eye sensitive troponin assays may be detected for a lot of individuals. So mentioning as elevated or not elevated is always better. So the universal definition of myocardial injury involves elevated cardiac troponin levels with at least one value above the 99th percentile of the upper reference limit. This is from the fourth universal definition of MI, where the term of myocardial infarction or injury, again rise of troponin level with at least one value above the 99th percentile. So one common thing we find, troponin or HS troponin, which should be used or which is preferred. Anything which is available in your center can be used, and preferably at the moment HS troponin is favored. Slightly higher diagnostic accuracy compared to the routine troponin. So preferably go for a HS troponin if it's available. And even among healthy individuals, we know that the routine assays, about 50% of cases, some value will be detected that will be within the 99th percentile. So that is where the HS troponin stays. So as I mentioned, anybody with the symptoms of chest pain, then you do a ECG and a troponin. The ECG shows an ST elevation MI. Then, irrespective of the troponin value, the patient needs to either go for a primary angioplasty or thrombolytic therapy, whichever, depending on the facilities available. It is very important to note this point because many times we see people waiting for troponin. ECG, ST elevation may be there, but let troponin come. If troponin is high, I will confirm the diagnosis. Otherwise, it may not be there. No. Troponin is not all needed in that situation. ST elevation can straight away go to the cath lab or thrombolytic therapy. Many times, patients present within that 3 to 4 hours time interval, and even with the 100% occluded vessel with a severe LV dysfunction, we see that the troponin is within the normal range. Sometimes it is hard to convince the patient attenders. They won't believe what we say about the ECG. They go by biochemical values. Any lab shows a higher value, they'll be happy that, okay, I approve that it is MI. Don't do that. If it's an ST elevation on the ECG, stop there, no further test, go to either to cath lab or thrombolytic therapy. Then, so once the ECG ST elevation is ruled out, then we suspect an NSTEMI, then we measure the troponin. So that is the 0 hours, that is at the moment we see the patient, do trop. Then the best algorithm, the troponin is normal, that is it is not elevated. Then you go for a repeat troponin in 1 hour. That will be the best option. Previously it was 4 to 6 hours, then came to 3 hours, then 2 hours, but now the current gold standard is 1 hour. So initial trop normal or not elevated, then you repeat after 1 hour, again not elevated, ECG is repeated, both are normal, then it is not a cardiac event. Maybe patient will need further cardiac evaluation once the MI is ruled out. And second best option, if immediate 1 hour algorithm is not difficult to follow, then we can repeat the value at 2 hours. So this is the algorithm from the EAC guidelines, which is relatively easier for us to follow. So suspected NSTEMI without an indication for an immediate invasive angio, that is patients who are not coming under the high risk category. No shock, no arrhythmias, no ongoing chest pain. Then do a troponin at 0 hours and 1 hour or 2 hours. We rule out based on these values, and if there is any other criteria fitting, either go to the observation pathway, or if it's positive or elevated, it goes into the rule-in pathway and further treatment based on that. So why troponin, though it is very sensitive, it is not specific to a cardiac MI. Why? Because there are a lot of other conditions apart from ACS and heart failure where it may be elevated. We commonly get this from the ICUs. Troponin is elevated. Is the patient having any additional MI also? A lot of conditions where mainly it is the HS troponin which gets elevated, both acute and chronic conditions. So acute conditions like neurological episodes, ischemic stroke, ICH or subarachnoid hemorrhage, sepsis, pulmonary embolism, rhabdomyolysis, end-stage renal disease, blunt chest injuries or poisoning. All these cases, troponin may be elevated. The important part to be noted here is why was the trop done? I think that is more important. Patients having any symptoms related to that and troponin done will have a better clinical correlation than just patient presented with the ARDS. Let me rule out an acute MI also, do a troponin. That may not be the way. So as we see, look at the time of onset of MI and the elevation of cardiac troponin. Very early sampling may not be elevated. Then 3 to 4 hours later, the early sampling slowly increases, and then it starts to decline by about 10 to 14 days. By 14th day, usually it comes back to normal levels. So then, are all cardiac troponin assays equal? Many times we receive calls from outstation where they say that nearby they did a troponin which was normal, then immediately they went to higher center, it was high, at the same time it was done. Can it be true? Yes, definitely, the assays are different. One lab may be different from another. It may be a point of contact test, or it could be a laboratory one. So we should remember that the assays are not always equal, whatever the values from one lab with another. With the current generation, the 4th generation is what we are following. Again, as I mentioned, HS troponin will definitely be better in all scenarios compared to the routine one. So what is the turnaround time of any troponin test? Even in big corporate institutes, we often tell that it takes a long of time for troponin report to come. So get it as soon as possible. So the benchmark will be 30 minutes. So 30 to 60 will be the cutoff. Beyond 60 minutes, if it's taking, then the lab should be informed that they should hurry up. So 30 minutes cutoff will be the best one, maximum of 60 minutes for turnaround time for a troponin assay. As you know, time is critical in this situation. So make sure that our hospital, wherever it is, the turnaround time is maintained. The point of care troponin assays definitely are valuable in this situation. Next moment you know what is whether trop is elevated or not. The quantitative assays take some time, though they are the best. So here, as I mentioned, it is the clinical management part. The turnaround time, the blood needs to be collected if it's from the emergency department, then to the lab, processed, result validation, and final information to the clinician. All this is informed in the turnaround time. This should be ideally 30 minutes to 60 minutes. So, coming to the point of care troponin assays, a lot of companies are there which provide immediate point of care services where it's either positive or negative, we know, though the quantitative value may not be there. These assays do not get a pass on the quality. So we should remember that central laboratory troponin assays are definitely better than the point of care. But one area where the score is the shorter turnaround time, as I already mentioned. Point of care utilizes whole blood, as we know. The quantitative assays is from the serum sample. 30% lower detection compared to the serum measurements. So lower sensitivity and lower diagnostic accuracy. So by all terms, the quantitative assays in the central lab is better. Only in terms of shorter turnaround time and a peripheral center, the point of care services should be used. Then another biomarker, as we know, is CKMB. It's outdated currently, should not be used as the first line measure if cardiac troponin assays are available, though they are detected earlier than troponin, 2 to 4 hours after myocardial injury, peak at 24 hours, and normalize by about 3 days. Again, other conditions it can be elevated: skeletal muscle injury, hypothyroid, chronic renal failure, and severe exercise. But one main area where it can be useful is reinfarction. You treat a patient goes home, comes back on the 5th day with again a chest pain. So now, as I told, troponin will take about 10 to 12 days to come down. So if you do a repeat troponin, many times we see that they do a troponin still is high. So is it a reinfarction? No. Do a CKMB, the CKMB is not elevated, then it rules out a reinfarction. It can be due to other pathologies. And this is from the ACC-AHA. In contemporary troponin assays are available. CKMB and myoglobin are not useful for diagnosis of ACS at present. Then coming to the cardiac biomarkers in heart failure. So BNP and NT-proBNP, under any hemodynamic stress, it will be elevated. And again, the main focus for doing this test should be on suspected heart failure patients, signs and symptoms with risk factors who present to the emergency department. You have a dilemma where patient presents with dyspnea, fatigue. Commonly the dilemma is between pulmonary disease and cardiac. You do a BNP or a NT-proBNP in that situation. So should I get a BNP or a NT-proBNP done? Similar to what I mentioned about troponin HS-trop. Depends on where you are. Whatever is available, you can do it. The differences between the two are very, very meager, and the similarities are usually dwarfed. So it is dwarf the differences. So both can be used. Whatever is in your center, you can use it. Ideally, I am used to NT-proBNP, and rule in and rule out is very good. Availability also is there, and costing almost similar to the BNP, so may not be any difference. The rule out is very important here. So many times it's a call from the team where breathlessness, cardiac. So you do a BNP and you know that you rule out based on the cutoff point of 300. So I'll just skip this. So it mainly helps in ruling out cardiac issues and diagnosis of heart failure. Of course, there are other conditions where natriuretic peptides can be elevated, similar to a troponin. And troponin can also be elevated in heart failure. We should remember that it indicates worse clinical outcomes, though myocardial ischemia may not be there. So key takeaways: troponin, highly sensitive marker of acute MI. If it's a STEMI, never wait for the troponin report to start treatment. CKMB, useful only for reinfarction. Lab testing always better than the PO, point of contact. 0-1R or 0-2R algorithm is standardized. And again, natriuretic peptides should be remembered for diagnosis of acute decompensated heart failure. Thank you. So, any questions?
Only one question is allowed in the interest of time, please.
Okay, sir. Sir, it was very nice presentation, sir. Only one doubt I have is that, sir, troponin value in case of male and females, whether there is any difference is there?
Sir, as per trials, there is a difference, but in clinical practice, they say the difference is insignificant. So, need not worry about that parameter at all.
Thank you so much.
Thank you, sir.
We thank profusely all the three speakers for their excellent deliberation on the respective subject. We'll like to honor them.
I request Dr. Vetrivel sir to give the memento to Dr. Saran. Sorry. Srinivas Moon. I request Dr. Aishwarya ma'am to honor Bala Vignesh. I request Dr. Sugma sir to honor Ronald Carey sir. I request Dr. Srinivasa Murthy sir to honor the chairperson of Aishwarya ma'am.
A token of affection and humbleness and affection, Professor Dr. Srinivasamurthy has got on us. When I witnessed in one of the huge conclave he hosted, most of us belong to Tamil Nadu. It's a very good affection. So API, Vellore District Branch feels proud and honored to honor Professor Dr. Srinivasamurthy with Sar. I request my chairman to honor Professor Srinivasamurthy. I request Balamurugan and Manigandan on the stage, please. I request Dr. Manigandan sir to garland our professor. I request our young physician, Dr. Balamurugan, to present the memento on behalf of Tapicon 2025. Thank you, sir. Thank you.
The last. The next session is session 5, Neurology. I invite Dr. G. Ilangovan sir, Dr. Gunasekharan sir and Palanivel Rajan sir to chair the session. And first topic is deep brain stimulation, current indication and future perspectives. I request Dr. Arvind G. sir to deliver his talk. Dr. Arvind, yeah. Momento, sir. Momento, sir. Momento. இல்ல sir. Momentoக்காக தனியா photo கேக்குறேன். தனியா photo. ஒண்ணுல sir.
Good evening, everyone. First of all, I thank and congratulate the team of Vellore API for wonderfully organizing this Tapicon 21. We profusely thank for giving the opportunity to chair this final session of the day one. The first two topics are interrelated. The deep brain stimulation, which will modulate the brain cells. Either it will stimulate or suppress the neurons of the targeted organ to give the effect either in the case of epilepsy or in the degenerative disease like Parkinson's. I request Dr. Aravind G. from Vellore to talk on deep brain stimulation, current indications and future introspection.
Over to Dr. Aravind.
Thank you, sir. Thank you for the kind introduction. There is some technical glitch. Yeah. One second. Sorry for the delay. I'm Dr. Arvind. I'm a movement disorder specialist trained in Enhance, Bangalore. So today I'm going to talk on deep brain stimulation, current indications and future perspectives. The photo that I've put is Dr. Robert Heath from US. He was the first person who tried DBS, but basically he was a psychiatrist and he tried it on psychiatry patients basically for pain and schizophrenia. So this was how it started, and then the actual use of DBS was currently is basically for movement disorders, and once again we have extended this to involve psychiatry patients also. Now it has come a full circle. It started with psychiatry patients, and now we have come back to psychiatry patients. So the disclosure, I have nothing to disclose. So the first thing, the objectives of this talk will focus on introduction to DBS per se, and then indications, and usually the common indication for DBS is movement disorders, Parkinson's, dystonia and tremors, followed by OCD and Tourette's. So in a brief introduction to DBS, DBS is not something new. It was known for a very long time. So electrical stimulation to modulate brain activity dates back to ancient times when they used electric fish to treat headaches and seizures. So the first, in 1947, Spiegel and Basis started the innovative apparatus. They created the apparatus and that marked the entrance of stereoencephalotomy and the use of intraoptic stimulation in patients with tremors, because ablative procedures is being done for a very long time. In that we found that when we used low frequency stimulation, it exacerbated motor symptoms, whereas higher frequency stimulation completely reduced it. So neuromodulation for treating movement disorders is possible. So Delgado used stimosivers, which I'll show you later. This is external stimulation. He kept something in the skull and used remote activation. And then Robert Heath, whom I've already shown you. And the last, in the 60s and 70s, almost 25,000 surgeries. And mind you, this is only ablative procedures, only thalamotomies was done. And almost 25,000 has been done by 1970. And then in Benabid in 1987, first did the proper DBS for an essential tremor. So this is the nucleus that he chose, which is the ventral intermediate nucleus of the thalamus, which is the site that we target when we want to do DBS in a tremor patient. So after this, we get a CE and a FDA approval for a gamut of diseases, starting from ET, PD, epilepsy, dystonia, OCD, and now we have included Tourette's also. So this is what has happened. In 1947, Spiegel and Weiss created the stereoencephalotomy, basically the stereotactic frame, and that moved on to the stimosivir, which was used by Delgado. In 1987, the first proper successful surgery was done by Benabid and colleagues in Grenoble, France, and from there, a lot of centers have started. NIMHANS has started this DBS from 2009. Probably we have a 16-year experience on DBS. So what is the mechanism by which this works? So there are 4 things that we generally say. It either inhibits or excites a neural activity in the area of excitation. And then there is something called information lesioning. Basically, it jams the neuron, not allowing the low frequency oscillations to go through, and synaptic filtering. By hitting the neurons with high frequency, we stop the neurons, we filter off the low frequency, which is the frequency which causes the dystonia tremors. So the next, basically this slide shows you the 3 volts current. When you give the 3 volt current, you can see the complete loss of beta activity. This is basically local field potentials of the STN, subthalamic nucleus. And once it goes to 0, you see once again it spikes. Beta frequency of STN, or the local field potential, correlates with bradykinesia. So when you have 3 volts, it's completely gone, it is suppressed, and once at 0, once again it spikes, telling us the neurostimulation works, right? So the next thing is indications. As I already told you, Parkinson's, dystonia, tremor, OCD, Tourette's, epilepsy, lots of indications are there. And more than that, you can see the others also. Addictions, for de-addiction we do, refractory aggression, treatment-resistant depression. The indications of DBS is widening as each day progresses. So in movement disorder, primarily we are concerned about Parkinson's disease. In Parkinson's disease, this is Claude Bernard. And then this is the picture that you always see whenever you think of Parkinson's. This is the caricature. He is a stonemason from France. This was drawn by Gower. Gower is the person who described the Gower's sign in the Duchenne muscular dystrophy. So this is we use the UK brain bank criteria. Now we use the MDS criteria for Parkinson's disease. In DBS in Parkinson's, it was basically approved in 2002. Why do we do in Parkinson's? Basically to control tremors and motor fluctuations and dyskinesias. How do you decide your patient requires a DBS? So that is, we have a Delphi criteria, 5, 2 and 1. 5 is for 5 tablets of Syndopa, 2 is for at least 2 hours of off time, disabling off time, and 1 is for 1 hour of troublesome dyskinesia, which hits the patient. In the on state, he is not able to do anything. So there are 2 studies, CAPSIT and early STIM. These are studies you always quote when you talk about DBS. So in CAPSIT, they said anyone age less than 70 with IPD diagnosis with 5-year duration of disease. Why do we need the 5 years? Basically because MSAP will look like PD and there will be no improvement when you do it in MSAP. So there's 5 years to differentiate atypical Parkinson from true Parkinson's, idiopathic Parkinson's disease. And levodopa responsive Parkinson symptoms are the things that will respond with DBS. So early STIM is the next study that we always talk about when we talk about DBS. In this, they reduced the duration. They said, no, it's not 5, we go for 4. And one of the problems with the shorter duration is When you have variants like GBA, they have a very poor outcome because surgicogenomics, the next new thing in DBS. For the last 5 years, we are more concerned about that. There is, what is the suitable age? Is there any age? No, we have done for 75 years also. So there's no specific cutoff. It's like thrombolysis in stroke. So what are the things that we should consider? The comorbids, the cognitive performance. A dementia patient is not a good patient to do, right? And then levodopa resistant symptoms. They are not going to improve even if you do a DBS. DBS is for symptoms which respond to syndopa. And the risk of surgical complication. So what is the importance of pre-op levodopa responsiveness? This is the primary thing that you should know before you do a DBS. The best predictive factor for a good response post-surgery is a good levodopa response prior to surgery. So levodopa responsive resistant features like gait and balance, dysarthria and dysphagia usually do not improve, they might even worsen. And severe tremor is the only exception. A drug refractory tremor will go away when you do a DBS, and if you have a patient who is not responding to syndopa, send him directly for a DBS. So what is a cognitive dysfunction? If there is severe cognitive deficit, do not go for DBS. If the patient has severe depression, once again, a very, very poor patient for DBS. Comorbid conditions, nothing is absolute contraindication. You can do anytime. MRI, if there is a severe atrophy, think before doing a DBS. But it's not an absolute contraindication. Social factors, if he does not have a good support, do not ever do a DBS because the patient will require good care post the DBS because you cannot give the proper drugs and when you start the stimulation. The targets are 3, STN, HGPI and VIM. Basically, I'll show you. Basically, STN and GPI, it depends only on the cognition and basically on cognition. The cognition is poor, you go for a GPI rather than the STN. And if you want a reduction in medication, you go for an STN rather than the GPI. Two things, STN is a small nucleus, so the battery life will be very good, whereas GPI is a large nucleus and the battery life will be less when compared to STN. So the targets, the PPN, basically for freezing, one of the things that we are not able to treat with STN and GPI, PPN for freezing of weight has been advocated, but still in NIMHANS we have not yet done for any patient. The others are cortisone inserta for the tremors, and CMPF and SNR are also tried. So this is two famous personalities. One is Muhammad Ali, the famous boxer, and Michael J. Fox. His trust funds most of the studies in Parkinson's. So to summarize in DBS in PD, do not do in atypical Parkinson. There is not going to be a good outcome. Active psychosis, uncontrolled depression, significant axial symptoms, they are very difficult to program also. And poor levodopa response, a very bad indication for doing a DBS. The contraindications which are relative is age, comorbids, distinct brain atrophy, psychiatric disorders, and a poor social support. So moving on, I'm just going to show you a video. So basically, this is the patient in off state. You can see the tremors that is starting in the right hand. So there is a tremor, then there is a bradykinesia, it's very slow. And there is so much of pauses when he's trying to do. Look how slow he is. This is a supination pronation moment. And he walks with short steps, reduced arm swing. He is stooped, takes multiple steps to turn. Luckily, he is not So we tried something new and we have published this. We gave him gave him haloperidol, 5 mg TDS, and I'll show you what happens after haloperidol. If I had skipped it, it would be easy. Okay. So this tonic spasms, this tonic spasms and this retrocollis and this backward bending of the trunk is very classical of primary torsion dystonia, PTD or open ends dystonia. You can, once you see it, you will know when the patient comes. You can make a diagnosis just like looking at the patient, but you have to do a genetic test. He cannot stand, requires support for everything. And then we gave him facial dystonia, right? And this is how he writes. He cannot hold, he cannot sit straight and write. So he arches back and he keeps. There is dystonia of the hand also, so he cannot hold it properly. So this is how he writes. And he cannot eat also. This is how he was fed. When he came to us, he used to lie in the prone position in the floor and they had to feed him like this. So I just keep. So we gave him haloperidol and he became completely Parkinsonian. And so we had published this in JMD. So this is only one case. We have never repeated this again. So we have done DBS for him. And now this is how he is completely normal. So I'll skip. So next is tremors. Tremors also shows an extraordinary response when you do DBS. You know the classification of tremors, axis 1, axis 2. Axis 2, this is a chronic progressive syndrome. So step 1 is to give primidone or propranolol, which is the best drugs. If they don't work, go for the second line drugs. If they don't work, go for Botox. Doesn't work, go for DBS or MRG FUS. This is from so how do you select? We have a multidisciplinary team. It is not just a neurologist who selects the patient. It's a psychiatrist, social worker. Everyone takes a call on this. So we usually use VIM. VIM nucleus, that is the site for DBS. You can also do a thalamotomy. If you don't put a burr, it is called MRGFUS. So without opening, it's called MRGFUS. You open and do, it's called a congenital thalamotomy. So FDA has approved both. So why is DBS preferred than thalamotomy? Because thalamotomy is a permanent lesion, cannot be reversed, and you don't have the chance of modulating. If after 2 days the tremors come back, you have to do it again, right? So propranolol primidone will produce a tremor reduction of 50%, whereas VIM will have a reduction of about 90%, right? In OCDs, the indication is basically you have a 5-year duration of OCD which is severe, and there is no improvement with drugs. Specifically, you avoid doing holding patients because they are not good candidates, and if there's a severe psychiatric disorder along with the OCD, do not do for them, right? In Tourette's, once again I'll show you one video. I'll just show you one last video and I'll stop this. Can you just open this? So DBS is one of the best options that we have when basically you have a treatment resistance or a severe motor fluctuation in PD and a very severe dystonia as well as severe tremors, which are basically both ET as well as PD when drugs are not working. And in OCDs and Tourette's, we have very good improvement in Tourette's also. Last is like 67 or something. So Tourette's, we had one kid, like he was on 5 antipsychotics and he was shouting the entire day. Whenever you go near him, he will shout bad words and he'll try to hit you. He had such severe phonic as well as vocal as well as motor tics, right? So we did DBS and he became absolutely normal. This was published by us in 2017. It's an old case. This one. We'll play, yeah? I'll play this. It's playing? Not playing. Sorry, okay. So for want of time, I'll skip this. It's not playing. So he became absolutely fine. So that's the last of my slides, and these are my references. And before I conclude, I want to thank my team at NIMHANS, Professor P.K. Paul, my other mentor, Professor Ravi Yadav, Nitish Kamble, and Vikram Hola. These are my senior professors who have taught me a lot about DBS, Botox, and everything about movement disorders. Thank you.
What would be the cost of treatment for the DBS?
So basically, the entire package, that is the IPG, the pulse generator, and the extension set, the entire set costs around 13.5 lakhs, sir. In NIMHANS, the entire package of doing also will cost you around 14 to 14.5 lakhs.
How long they have to stay in the hospital?
Sir, we will ask them to stay for at least 7 days. Prior to the surgery for 3 to 4 days. Before that, we will assess them for 7 days.
Have you ever come across GPI, syphilis, in your practice?
No, sir, I have not seen, sir. General paralysis of insane, I have not seen, sir.
Yes.
Yes, sir. Sir, deep brain, sir, for the cognition. Sir, it does not have a role in cognition, sir. Post-traumatic, if it is in the basal ganglia, patients have dystonia, post-traumatic dystonia. Cognition part, it's not done, sir. Yes, sir. Thank you, sir.
Thank you very much, Dr. Aravind. You have extensively given an overview about deep brain stimulation and various indications. Thank you.
Thank you, sir.
Next, we will call upon Dr. Muthu for the talking about the other part of the Parkinson's disease, treatment modalities, recent aspects, apart from DBS.
Good evening. At the outset, I thank the organizers for giving me this opportunity. We have discussed in the previous session regarding DBS. Now I'm going back to the medical management of Parkinson's disease. For the PG's sake, I will discuss some basics about Parkinson's disease. The journey of Parkinson started from James Parkinson, his first article, an essay on shaking palsy. It was Charcot who named the shaking palsy as Parkinson, and he honored Parkinson by naming it as a Parkinson disease. So the prevalence of Parkinson disease is 1 per 800 and the annual incidence is 1 per 8,000. 1% of people aged more than 65 years are affected by Parkinson disease. So I'm skipping the pathogenesis. Coming to the diagnosis of Parkinson's disease, the gold standard is by pathology. The two key criteria are atrophy of the dopaminergic cells in the substantia nigra and accumulation of alpha synuclein in Levy bodies and nutrients of the brain. When we see some patients with a clinical diagnosis of Parkinson's disease, almost 60% of dopaminergic neurons are already lost. Coming to the clinical diagnosis, the diagnosis is by MDS-PD criteria, which contains the major motor manifestation, namely bradykinesia. Bradykinesia is the key feature to diagnose Parkinson's disease in combination with either resting tremor or rigidity or both. The supportive criteria includes beneficial response to dopaminergic therapy, levodopa-induced dyskinesia, hyposmia, and cardiac sympathetic denervation demonstrated by MIBG. So, the motor symptoms of Parkinson's disease, remember it as TRAP. The key finding being akinesia or bradykinesia, which includes slowness as well as hypokinesia. Hypokinesia is progressive smaller movements when we do a repeated action. The next one will be tremor, 4 to 6 sets resting tremor, which disappears when the arm is stretched or when we do some action, and it recurs again, which is, hence it's called as re-emergent tremor, and the tremor is usually disappears with action. Rigidity is involuntary, velocity dependent, resistant to passive movements. And postural instability, the impairment of balance, making the patient unable to change or maintain a posture like walking or standing. So other classic motor features are flexed posture as well as freezing. So coming to non-motor symptoms, this includes olfactory loss, sleep dysfunction in the form of rapid eye movement, sleep behavior disorder, daytime sleepiness, and sleep maintenance insomnia. Important non-motor symptom will be autonomic dysfunction, which includes constipation, delayed gastric emptying, urinary urgency and frequency, erectile dysfunction, and orthostatic hypotension. Psychiatric symptoms include depression, anxiety, apathy, or psychosis, and cognitive impairment can range from mild cognitive impairment to dementia. So, all bradykinesias are not Parkinson's disease. So, when we come across these findings, be sure that it's not Parkinson. When you examine a patient with supranuclear gaze palsy, it can be a PSP. Bradykinesia with cerebellar symptoms, it can be an MSA. Parkinsonism restricted predominantly to the lower limbs for more than 3 years, it could be a vascular Parkinson. Prominent dementia can be FTD. Recent treatment with the dopamine receptor blockers or absence of response to dopamine, cortical sensory loss, all these features say this is not Parkinson's disease, means idiopathic Parkinson's disease. Again, these are the red flag signs. When we see a case with bradykinesia, resting tremor, we have a confusion whether it is a Parkinson's disease or a Parkinson plus syndrome. It's very important to differentiate between the two because it's idiopathic Parkinson's disease responds very well to therapy and the longevity is more compared to Parkinson plus syndromes which do not respond to syndopa. So look for these red flags: rapid progression, requiring the use of wheelchair within 5 years, no motor progression for 5 years, which suggests presence only essential tremor, bilateral symmetric disease, early bulbar dysfunction, which focuses to MSA, respiratory dysfunction like stridor, which suggests again multisystem atrophy, severe autonomic failure within 5 years, again suggests MSA, recurrent falls before 1 year or within 3 years of diagnosis suggests PSP, and disproportionate enterocolis, which suggests MSA, and unexplained pyramidal signs. Again, when it can be a pure Parkinsonism or along with Parkinsonism, a presence of additional features which points towards a Parkinson plus syndrome. So Parkinson has a prodromal stage and then followed by a diagnostic period. So this is the time travel of Parkinson's disease. Coming to the management of motor symptoms, the first thing we have to identify whether it is a pure idiopathic Parkinson disease or a Parkinson plus syndrome. Again, we have to subtype Parkinson, whether it is a tremor predominant or postural instability, gait difficult condition or an intermediate group. So what are the drugs available to treat Parkinson disease? It's levodopa preparation, which can be so we have got the 6 group of drugs. The first one will be levodopa. Levodopa is the most important drug, most efficacious drug, which we get in the 4 formulations: immediate release carbidopa, controlled release carbidopa, extended release, and enteral suspensions, as well as inhaled levodopa. The next one will be dopamine agonist, which includes pramipexole, ropinirole, and transdermal rotigotine and injected apomorphine. The other drugs are MOB inhibitors, which are selegiline, rasagiline, safinamide, and COMT inhibitors, entacapone, opicapone, and others are anticholinergics, amantadine, istadeflane, and clozapine. The dopamine is a miracle drug. It has been in use for the more than 50 years, and still it's the key drug to treat Parkinson disease. It's the most effective, and global anti-Parkinsonism efficiency of levodopa is so dramatic and predictable that positive therapeutic response is used to define the disease itself. So the adverse effects of levodopa includes nausea, vomiting, orthostatic hypotension, confusion, sleep disorders, and later motor fluctuations. So dopamine agonists, we have in the tablet form, we have pramipexole, ropinirole. Rotigotine is available in the patch format, and sublingual as well as subcutaneous injections, we have got apomorphine. The most important side effect of a dopamine agonist is impulse control disorders like gambling, hoarding, excessive shopping, binge eating, and hypersexuality. If we see ICD in a patient taking dopamine agonist, we have to stop and withdraw dopamine agonist. So what happens when we withdraw dopamine agonist? We may land up with a dopamine agonist withdrawal syndrome characterized by agitation, anxiety, depression, and autonomic symptoms like orthostatic hypotension. Amantadine is a NMDA receptor antagonist. There are extended release forms are available. It has a mild anti-Parkinson drug, anti-Parkinsonism effect, and it's very useful to treat levodopa-associated dyskinesias. MOB inhibitors, selegiline and rasagiline, the Adagio trial showed early benefit of using rasagiline in treating Parkinson disease instead of levodopa, but later trials showed that rasagiline did not show substantial benefit in these conditions. Again, safinamide is another MOB inhibitor, which is used in the off period while treating Parkinson disease. So anticholinergics, they are very useful to treat especially tremor aspect of Parkinson disease. Adenosine A2 antagonist, this is istradeflane. It is used as an adjunctive to treat along with L-dopa when the patient is experiencing off periods. It's available as 20 milligram and 40 milligram tablets. It provides a modest benefit in treating patients with motor fluctuations. So these are the non-motor symptoms, and I have mentioned the drug of choice. Depression can be treated with SSRI, apathy. If you see impulse control ICD, no other go, we have to stop dopamine agonists. Hallucinations and psychosis, pimavanserin is a drug of choice. Quetiapine is other drug, because any other drug like haloperidol or risperidone may aggravate Parkinsonism. So Parkinsonism associated hallucinations and psychosis, pimavanserin or quetiapine are the most effective drugs. Orthostatic hypotension can be treated with droxidopa, midodrine, And urinary dysfunctions, we can try solifenacin. So when we start a patient on levodopa, there are certain symptoms which do not respond to levodopa. So the most important, there are 4 symptoms which do not respond to levodopa, which includes freezing gait. It is a motor akinesia. Patient is not able to move his feet for up to 10 seconds. It involves the lower limb, but it can also affect the arm and eyelids. There are 5 types of freezing gait: start hesitation, turn hesitation, hesitation in tight quarters, destination hesitation, and open space hesitation. Certain tricks will help to overcome the freezing attacks, like stepping over objects. So when patient frequently faces these freezing episodes, they tend to fall. So to overcome, some objects can be placed on the like steps, so that patient can walk over the steps. So other levodopa resistant symptoms are dysarthria, dysphagia, resistant tremor, and postural instability and dysautonomia. Resistant tremor and symptoms like blepharospasm, apraxia of eyelid opening, antrocholis, they can be treated with Botox. We know levodopa is the most effective drug, but over the time we see the reduction in duration and reliability of motor symptoms, which is called as motor fluctuation, and the emergence of new abnormal movements, which is called as levodopa-induced dyskinesia. These are the long-term complication of levodopa, motor fluctuations and dyskinesias. So the motor fluctuations include wearing off, that is, the effect of drug is lost. And on-off fluctuation is unexpected loss of the effect of levodopa, and sudden random off is unexpected sudden off period. So you have in mind, on is patient is getting response to levodopa, and off is the patient do not get response and he is going for severe bradykinesia or akinesia. Delayed on is delay in the manifest effect of drugs, dose failure. So these are the motor fluctuations, and there are 3 types of levodopa-induced dyskinesias: peak dose dyskinesia, which affect diphasic dystonia, as well as painful off dystonia. So younger age of onset, worse disease, and higher levodopa dose may result in motor fluctuations and levodopa-induced dyskinesias. So levodopa dose above those required for adequate control of symptoms should be avoided, as higher dose results in more motor fluctuations and dyskinesias. This will help to understand the dyskinesias and off symptoms. Lack of time. So what are the reason for motor fluctuations? The oral drug what we take has a pulsatile effect instead of the physiological dopamine, which acts continuously. So as the disease advances, the presynaptic terminals in basal ganglia, they lose the ability to uptake dopamine and store. So only when we give a continuous dopamine, we will have continuous effect and we do not face with motor fluctuations. But oral dopa results in pulsatile dopamine release, and hence we face with fluctuations. So how to overcome this pulsatile drug release? This is done by infusion 2 techniques: infusion therapies and on-demand therapies. Infusion therapies, we give the drug levodopa and carbidopa combination as a continuous infusion, and on-demand therapies we take whenever patient goes for off phenomenon, which includes dopa inhaler, apomorphine sublingual film, as well as apomorphine pen injections. These are the infusion therapies. Apomorphine is a very short-acting dopamine agonist, which is used for off period. So apomorphine can be used as in both intermittent way as well as an infusion form. Intermittent is useful in severe off period, sudden off and delayed on, and as well as morning akinesia. Infusion is useful as a frequent rescue dose as well as in peak dose dyskinesias. Duodopa is a levodopa carbidopa combination which is given as in a gel form. It's given as a duodenal infusion, so that the gastric motility aspect is overcome and we get a continuous drug infusion. The next drug is levodopa entacapone carbidopa intestinal gel, the same mechanism as levodopa carbidopa intestinal gel. So the next mode of treating off state is inhalation levodopa. It's an intrapulmonary levodopa powder formulation. It acts only for 90 minutes and it acts within 150 seconds. So the patient comes off the off period immediately. The next one will be fast levodopa, fast carbidopa, continuous subcutaneous infusion. This modality it reduces the motor fluctuations by 2 hours. It increases the on time by 3 hours and no troublesome dyskinesias observed. So to treat in the early stages, Parkinson very well responds to syndopa and there will not be any motor fluctuations. But in advanced cases, we have to, still levodopa is the drug of choice, shorter interval between doses, treating constipation, taking drugs in an empty stomach, extended release formulations, combining with the dopa agonist, or the phenomenon to overcome the fluctuations. Similarly, as discussed by Arvind, DBS is a drug, DBS is a modality to overcome the motor fluctuations. Currently, there is no randomized trial that has compared the efficacy of various advanced treatments. However, deep brain stimulation is the most positive, has got the most positive effect, but the highest potential for adverse effects. Thank you.
Excellent. Is there any question? One question may be allowed. If there is no question, we have come to the final presentation of the day. I request Professor Appanraj, Melmaruthar Medical College, Chengalpet, for GB syndrome, the recent outbreak. Professor Appanraj is a dynamic teacher. Not only a teacher, he is a multifaceted personality. He is very... So, over to Appanraj. For want of time.
Good evening or good night. Okay, so anything can be right. So at the onset, I want to thank the organizers for giving me this opportunity. After the 2 brainstorming sessions by the neurologist, it's going to be in a lighter vein because we are going to talk about the GBS outbreak, recent outbreak. Thank the chairpersons for giving a nice introduction. So, see, the topic is Guillain-Barré syndrome, about the recent outbreaks that have happened in our country. It's a rare autoimmune disorder, we all know, that affects the nerves. And it has to be noted very fast, and the symptoms has to be captured as early as possible, because the early the treatment starts, the recovery will be very good. So that's why we should know about the outbreaks in India. See, the first, in month of January, in Pune, India, the cases have been reported, a cluster of cases have been reported about the Guillain-Barré syndrome. Approximately 160 cases have been reported in that month itself, and 5 suspected deaths because of the GBS has been occurred. So many patients needed intensive care and ventilator support. So still, till now, within this year itself, over 230 cases till now in Maharashtra, 17 reports have been, deaths have been reported, and most of them have been linked to the Campylobacter jejuni in the water, and the areas affected mainly are Pune, Nagpur and Mumbai, and WHO deployed their response teams in order to overcome this disease. So, and GBS cases in other Indian states have been reported in this year. Kerala, 2 deaths have been reported, Andhra Pradesh, 5 confirmed cases and 2 are critical. In West Bengal, 2 child fatalities have been noted. And in Karnataka, again, health alert has been issued, and in Tamil Nadu also cases have been reported, but no deaths have taken place in this year. So the cause of the outbreak, see, it's a Campylobacter jejuni. It's a common foodborne pathogen. This is the leading cause of GBS worldwide, not only in India. So prior infections are common in GBS patients with the Campylobacter as a significant factor. So global impact and other triggers. There have been a lot of outbreaks of Campylobacter jejuni associated GBS have been reported in many countries, and there have been cluster of cases, okay, endemic has been seen in Peru in 2019 and also in 2023. In countries where the food and sanitation is very good, so where waterborne diseases are very less, still the global impact can be because of the respiratory infections which contribute to the GBS. See, other than this, we can find out Zika virus, EBV virus, CME virus. So all have been, even HIV, have been linked to these diseases. And so this is mainly because of the Campylobacter jejuni has a sugar-coated outer layer which mimics that of the human nerve cells. So because of the molecular mimicry, our immune systems try to attack the Campylobacter, but attacks our own nerves. That leads to the Guillain-Barré syndrome. So key findings of this public health responses, Campylobacter jejuni is the main one. So early detection have prevented many deaths in the later part of the period, and prompt IV immunoglobulin therapy improved the outcomes, and sanitation and water safety has been emphasized. So now just GBS is a acute monophasic immune neuropathy causing paralysis. So approximately 1 lakh cases have been reported in entire world in a year, and this has very good impact on the economy as well as disability of the patients, because some of them can have chronic debility also. So it's a rare autoimmune disorder. It causes muscle weakness, paralysis, and in severe cases it can go for the respiratory failure. So there are 1 lakh new cases every year, and lowest in Japan and highest in Bangladesh. These can be attributed to the sanitation. So seasonal patterns exist. In India also, most of the cases will be coming in June and July. And when it comes for the age, older age are affected more, and males are affected more than the female. And previous infections of Campylobacter, that is either diarrhea or respiratory, are very common. And vaccines have been attributed, but it is not to the extent that has been thought previously. And even cases have been reported after post-COVID-19 vaccine. And there have been some of the Johnson & Johnson vaccine have a note, okay, this can cause GBS like that. And GBS variants, which everyone know. So AIDP is the most common disease of the West, and AMAN affects the motor nerves. It's more common in China and Japan, that is mostly Asian countries. And AMSON is most severe of them. It affects both the motor and sensory. It's an axonal neuropathy, and it has the worst prognosis, and it can have debility for a longer period of time. And we have the Miller-Fisher variant, where it only affects the ophthalmoplegia, ataxia, and areflexia. So possible triggers, it could be Campylobacter jejuni, influenza virus, COVID-19, HMPV, HIV, EBV, CME, etc. So it is because of the autoimmune response that attacks the nerves, causing paralysis and the weakness. So 5 A's we should remember in Guillain-Barré syndrome. The first is acute inflammatory demyelinating polyradiculoneuropathy. It's a rapid inflammation that affects the multiple nerve roots. It targets and destroys the myelin sheath. So there will be a nerve signal transmission disruption that takes place. So it is an ascending paralysis. So weakness begins in the lower limbs and progresses upward. So it can affect your arms, torso, and the respiratory muscles at last, and rapid progression can take place. So within 2-3 days, patient may need mechanical ventilation in severe cases. And third A is autonomic dysfunction. So it impacts the involuntary bodily functions. It can cause rapid blood BP fluctuations. It triggers abnormal heart rhythm variations, and it may need continuous cardiac monitoring in most of the cases. And albuminocytological dissociation is a unique diagnostic marker in the cerebrospinal fluid. So though it can present in CADP, your history will be helpful in differentiating between AADP and CADP. And most of the cases here, there will be elevated protein levels with the normal white blood cell count, unlike your meningitis where WBC count will be increased. So it requires the lumbar puncture for confirmation, and it can differentiate it from the other neurological conditions. And fifth is areflexia. So 90% of the patients exhibit the diminished or absent reflexes. It indicates significant peripheral nerve involvement. It is critical in diagnosing most of the cases of AITP, and it confirms the neurological compromise. So the 5 A's: acute inflammatory demyelinating polyradiculoneuropathy, ascending paralysis, autonomic dysfunction, albinocytological dysfunction, so dissociation, and areflexia. So diagnosis is mostly clinical. We have criteria. So we have to go for the clinical methods as well as lumbar puncture and nerve conduction study. If everything is present, level 1. So if only clinical as well as either one, it's level 2. Okay, sorry for this slide. So GBS is very highly likely whenever it follows a gastrointestinal infection or a respiratory infection, presenting with ascending paralysis, areflexia, and if there is minimal or very minimal sensory symptoms, cranial nerve involvement, okay, we have to think it is because of the GBS. So GBS should not be excluded just because patient is not having hyporeflexia in the first week and not having hyperreflexia in the first 2 weeks, and normal CSF protein in the first week, and normal electrophysiological studies in the first 2 weeks. So because they can have effect after 1 or 2 weeks. And GBS should not be excluded, but it is very unlikely. So whenever there is a progression of symptoms even after 4 weeks and recurrent treatment related fluctuations taking place, but it's not so. It's either worsen, it will recover. And early sphincter disturbance acts against it. So GBS is unlikely whenever it is asymmetrical, whenever there is isolated respiratory failure without weakness, and there is a progression of symptoms even after 8 weeks. So hyperreflexia, if persistent for more than 2 weeks, and patient having normal electrophysiology even after 2 weeks. So there are differentiating features from acute onset CIDP and HIV, acute intermittent porphyria. When it comes for the muscles, hypokalemic periodic paralysis should be kept in your mind. And acute viral myositis, neuromuscular junctions, we have to think of myasthenia gravis, okay? And acute transverse myelitis, and even brainstem stroke and rhabdoencephalitis has to be taken into consideration. So the common misdiagnoses are stroke, multiple sclerosis, and myasthenia gravis. So important, why we have to diagnose them very fast is faster treatment, better recovery chances. Support GBS and research and patient recovery is very important. So the first line therapies is IV immunoglobulin and plasmapheresis. Both are equally effective, and whenever the center has any facilities, you can use both of the things depending on the patient. One removes the antibodies, another blocks the antibodies, and IV immunoglobulin is easy to give. So choosing the treatment, IVIG is easier to administer, and IVIG is 2 gram per kilogram that has been dissociated in 5 days. In 5 days, so it comes under 0.4 gram per kilogram per day. And plasma exchange removes harmful antibodies. IVIG blocks the damaging antibodies, and supportive care is very, very important part. So rehabilitation therapy, usually recovery can take place even 6 months to 2 years, and 80% recover within months to years, and 5 to 10% can go for permanent disability. GBS relapse is very rare, but it can occur. It can mimic CIDP in most of the cases. So GBS is not contagious. Only the infection that occurs before it is contagious. GBS always causes permanent paralysis. No, it is not so. Only in 2 to 3% it causes in longer term effects. Only older adults get GBS. It can occur at any age. And proper hygiene, early treatment of infections, and monitoring post-vaccination reactions are very useful. And emerging treatments, drugs like eculizumab, targeting the complement protein C5 is shown very limited efficacy in the trials, so that has not been approved. And IgG degradation, imlifidase, an enzyme that cleaves the Ig antibodies, is under phase 2 trials. It has reduced the oxonal injury, so it will be helpful once it is getting approved because of its novel approach. So yearly recognition is very important. PGs, just remember the 5 A's: acute AIDP, ascending paralysis, autonomic dysfunction, albuminocytological dissociation, and areflexia. Thank you. Thanks for the opportunity.
Thank you, Dr. Appanraj. Very good, crisp, and neat presentation. Thank you. This immune-mediated inflammation at the neuromuscular endings is the cause is not known, but these Campylobacter and Zika virus and other viruses are implicated.
Yes, sir. Yes, sir.
In its
It's been
presence,
implicated.
the immune-mediated thing is happening as an inflammation.
Yes, sir.
in the neuromuscular end.
Usually it is happening 2 to 3 weeks or 4 weeks after the infection, so they are
Okay.
able to find out.
That's why we are not giving any antibiotic.
Yes,
Instead,
sir.
we are
Antibiotic
giving
is not
immunoglobulin and plasmapheresis.
Yes.
That's right. Very good. Thank you.
Thank you,
Thank you very much. Any questions can be asked.
Professor Appanraj, when K. Jagannathan, former professor of neurology, who described the Bedros motor neuron disease, whenever we present cases with Guillain-Barré, he expects to ask whether any history of diphtheria, post-diphtheritic,
Yes, sir.
proximal muscle weakness,
Weakness has to be
almost simulating the Guillain-Barré syndrome.
Guillain-Barré syndrome, yes, sir.
Proximal weakness,
I have
polyradiculopathy.
shown in the slides, sir, but I didn't.
That was he used to say that was a common thing in the infective phase. Now it has become non-communicable disease. It is the one simple thing I just want to remember. Thank you. Thank you. Excellent speech.
Thank you, sir.
Thank you, sir. I request Ilangovan sir to honor Dr. Muthu sir, the previous speaker. This ends the session in Hall B. I request everyone to go to the Kalai Kaveri function, which is there in the nearby auditorium ground floor.